they go, I must follow them. I am their leader. I think we'll go ahead and get our meeting started. Good morning and welcome. I'm Daniel Hancock, and I'm the chairman of the Little Hoover Commission. And before we begin, I'd like to introduce my fellow commissioners who are present, and there'll be several more coming, I think, and we'll introduce them when they get here. But to my right, far right, I have Commissioner Marshall Geller, and to his left, I have Commissioner Marilyn Brewer. To my far left, I have Commissioner Eloise Anderson, and to her right, Commissioner Martin Helmke. Also with us are the Commission's Executive Director, Stuart Drown, and our Deputy Director, Carol D'Elia. Also in the audience is our Project Manager, Whitney Barasoto, and our Research Analyst, Tamara Foster. This is the first hearing the Commission is holding to review the system of care for California's aging and disabled population. In this study, the Commission will review the spectrum of long-term care in California, including in-home supportive services, home and community-based care, adult day care, health care, and assisted living and nursing facilities. A subject, by the way, we're quite familiar with over the years. As part of this study, the Commission will identify weak areas in the state's network, try to recognize innovative and successful practices that should be expanded, and develop recommendations to strengthen the state's long care system. This hearing provides an opportunity for the Commission to learn more about the state's long-term care services and challenges to improving care services in California. This morning, the Commission will hear testimony from Lisa Sugarman, Director of Policy, and Sarah Steenhausen, Senior Policy Fellow of the SCAN Foundation, who will provide an overview of the major components of California's long-term care system. Next, Leslie Hendrickson, Principal of Hendrickson Development, will share recommendations to improve access to care and opportunities to improve the state's existing programs. The Commission will also hear from Lynn Dauscher, Director of the California Department of Aging, who will discuss the services available through her department and the role of the department within the state's network of care. Finally, Megan Juring, Assistant Secretary of the California Health and Human Services Agency, will provide an overview of the agency's current efforts to improve long-term care in California. There will be an opportunity for public comment following the testimony of the scheduled witnesses. Please notify the Commission staff at the desk if you would like to provide comment after the hearing. Today's hearing will be recorded by the California Channel. The Commission will hold its business meeting immediately following this hearing in room 125 of the state capitol. I would like to thank the witnesses in advance for their written materials that they submitted. We have had the opportunity to review those materials, so that I would ask that you summarize those materials in your testimony and make as much time available for questions as possible. I'd like to introduce our Vice Chairman, Mitch Mitchell, who has just arrived, and have the Executive Director call our first witness.
To provide an overview on California's long-term care system, we have Lisa Sugarman and Sarah Steenhausen as a panel. Lisa Sugarman is the Director of Policy for the SCAN Foundation. It's an independent charitable foundation that focuses on health care needs of California seniors. Previously, Ms. Sugarman was a health policy researcher with the RAND Corporation, where she focused on policy analyses related to vulnerable populations, including seniors and people with disabilities. Sarah Steenhausen is a Senior Policy Director for the SCAN Foundation, where she concentrates on developing a sustainable continuum of long-term care for California seniors. Ms. Steenhausen has held several senior-level positions in the California Department of Developmental Services and the California Health and Human Services Agency. Good morning. Thank you.
Welcome. Thank you for coming. And I think we'll start with Ms. Sugarman and then move on to Ms. Steenhausen. And you can go ahead and start. We'll probably interrupt you at some point.
Okay.
It's kind of the way it works here.
Good morning. Thank you for the opportunity to speak with you today. As you've already announced, my name is Lisa Sugarman. I'm the Director of Policy for the SCAN Foundation. Just a little bit about the SCAN Foundation. The SCAN Foundation was established in 2008 and is the only foundation in the United States with a mission focused exclusively on long-term care. The SCAN Foundation's mission is to advance the development of a sustainable continuum of care for seniors. To this end, the SCAN Foundation has three funding priorities. The first is around public engagement to elevate the establishment of a comprehensive continuum of care for seniors as a national priority and as a state priority for California. The second priority is around policy development to advance realistic policy options to establish and finance a comprehensive continuum of care for seniors. And finally, the third is around promising programs to support the dissemination and assessment of promising new program models that can inform and strengthen long-term care policy development. I'm pleased to be able to speak with you today about the long-term care policy environment. My written testimony provides a lay of the land for long-term care nationally, and today I will focus my remarks around the vision of a high-performing long-term care system. The SCAN Foundation is dedicated to the development and support of a sustainable continuum of care. We speak of a continuum of care more broadly than long-term care specifically, because when we say long-term care, most often people think of nursing homes and only nursing homes. Our interest is in supporting the broader continuum of care that includes home, community, as well as institutional-based services that are integrated with medical care services. Before I delve into the specifics of what a high-performing long-term care system should look like, I want to provide a brief overview of the size of the long-term care population and who provides these services. National estimates suggest that as many as 12 million individuals have a need for long-term care due to a physical impairment. This may underrepresent the number who need long-term care due to a mental illness or cognitive impairment. This translates to potentially as many as 1.5 million California residents who need long-term care. This number is certain to grow substantially as the baby boomers age. We can anticipate the size of the population age 65 and older to almost double in California in the next 20 years, and the working age disabled population to increase by approximately 20% in the same amount of time. Long-term care services can be provided in a variety of settings, including one's home as with home care services, in the community as with adult daycare or adult day health care, in residential settings as with assisted living or board and care homes, or in institutional settings as with nursing homes. Long-term care services can be provided by paid or unpaid caregivers, and over 85% of those who need long-term care get that care from unpaid caregivers, usually family members. Only a fraction of long-term care is provided by paid caregivers, and most of this is provided by direct care workers. There are over 150,000 direct care workers in California that include nursing assistants and aides, home health aides, personal aides, and home care aides. So the goal of the long-term care system is to enhance the well-being and quality of life of individuals who experience functional and cognitive limitations because of chronic illness, accident, or other causes of disability. There are several characteristics of a state's long-term care system that can make it a high-performing system. The SCAN Foundation, along with the Commonwealth Fund and the AARP Foundation, have built an ongoing collaboration to develop a long-term care scorecard for the states. As part of this project, we convened a panel of national long-term care policy experts to develop a set of working principles or elements that describe a high-performing long-term care system. These 6 elements are something the Commission might strive for when considering public policies that affect the organization, delivery, and financing of long-term care services. The 6 elements of a high-performing long-term care system are as follows: that long-term care should be person-centered, high quality, efficient and of high value, supportive of family caregivers, accessible, and integrated with the larger healthcare system. In my comments today, I will describe each of the 6 points in a little bit more detail. The first is that long-term care should be person-centered. If you ask most seniors, they'll tell you that they prefer to remain in their homes and in their communities rather than be moved into institutional settings. The ideal is for individuals to have a choice among a comprehensive array of long-term care options, including both home and community-based services as well as institutional care, and that consumer-directed care is a critical component of this. The second element is that long-term care is of high quality. High-quality long-term care services should be available in a variety of settings and in all geographic areas. The core elements of a high-quality system are that the right care is provided in the right place at the right time, that regulatory standards are consistent with quality, and that regulations are enforced, and that the necessary workforce is of sufficient size and adequately trained, and then finally that Medicaid payment rates are sufficient to support high-quality care. The third element is that long-term care is efficient and provides high-value care. This means that resources are used in a cost-effective manner to produce services that consumers value. States should use payment systems that incentivize providers to be efficient and provide high-quality care. On the provider side, an efficient system employs information and information technology in a way that supports planning at the individual program and system levels. The fourth element is that the long-term care system supports family caregivers. Family caregivers are a critical part of the long-term care system. The majority of long-term care is unpaid, and it has an estimated value of over $350 billion annually. Support for family caregivers means that information and supportive services are available for them, that family members are included as appropriate in decision-making and care planning, and that public programs offer benefits that support family caregivers, including offering respite and providing adequate training. The fifth element, that the long-term care system ensures access to care for all who need it. This means that long-term care services can be obtained easily and quickly when needed, that services are affordable, that everyone can afford to obtain needed services, and people do not need to impoverish themselves to qualify for long-term care services. Within the Medicaid system, this means that beneficiaries enjoy the same rights to home and community-based services that they do with institutional services, and that public spending is balanced between the two. While the focus of long-term care discussions usually center on the low-income population, specifically seniors who qualify for Medicaid, one of the major system-wide challenges lies in ensuring access to long-term care services for all seniors in need. Retired Americans living on a fixed income, but who do not qualify for Medicaid, often don't have the financial resources to pay for long-term care services for any sustained period of time, and they are faced with the fact that they have to impoverish themselves in order to receive the services that they need through Medicaid. This is a terrible way to live out the last years of one's life and makes for bad public policy. The sixth and final element of a high-performing long-term care system is that the long-term care system is integrated with the larger healthcare system. In a high-performing system, integrated, coordinated, easy-to-access services are available across the range of long-term care and medical services. The various people involved in an individual's long-term care and medical care are capable of communicating with each other, and information is easily shared among all providers involved in the management of an individual's care. So the issues and challenges confronting California's long-term care system are many, as will be outlined in the accompanying testimony by my colleague, Sarah Steenhausen. As you hear the rest of the testimony today, as well as when considering what policy recommendations might come from the Commission, we urge you to keep the 6 elements of a high-performing long-term care system in mind. And again, just to recap, those are that long-term care should be person-centered, high-quality, efficient, and of high value, supportive of family caregivers, accessible, and integrated with a larger health care system. With that, I will conclude my remarks. Thank you again for the opportunity to speak with you today.
I think Commissioner Mitchell wanted to ask a question before we move on.
Thank you very much for your testimony. I was commenting that in reading your testimony and reading all the backup material that this is a complex situation, and your 6 points, resonate. But in reality, in looking at the numbers, all the things that you want, there's a cost associated with them.
No doubt.
And you mentioned, for instance, Medicaid payment rates need to be appropriate, et cetera, which you're basically saying the reimbursement rates for. Explain that aspect of it.
Sure. Well, you want to make sure that providers are being paid a sufficient amount of money that enables them to provide the care that they need, that allows them to provide the right kind of staff and to provide the right services that are needed to produce the best outcomes for the individual. Okay.
Now, a lot of the testimony points to the community-based system works best. You leave people in their homes, et cetera, et cetera. But again, on your 6 points, some of this is in place today. It's just not. It's not adequate. When we did the Medi-Cal study a couple of years ago, one of the things we realized is that we talk about Medi-Cal being comprehensive for people who are qualified economically, but there are huge gaps because you don't have doctors and dentists and services in large areas of the state.
Right.
So what you're talking about when you say access to all and integrated with the larger healthcare system, that doesn't exist today.
It does not.
It does not exist today, and the problem's only going to get worse.
I guess I should say it doesn't exist everywhere. So it may exist in small pockets in certain communities, but it is not all citizens don't have equal access to that system.
Okay, now on the support family caregivers, though, on that concept, what you said is they need to have access to information and they need to have training and support.
Yeah.
Because I think somewhere in the materials it says that 2011 is really our crisis year as a state.
That's
because
when the baby
boomers all
right.
start to retire.
Right.
So you will have all the family support members looking at how they address that issue.
Yes.
But now today, if you are a family caregiver, what's available to you today to help you adjust and prepare and be adequately trained and all of those things?
So there are some programs that are available, and there's some really promising opportunities out there. The ADRCs, I want to say. Yeah, do you want to talk about ADRCs?
Well, one example of a program that has been very successful in serving caregivers is the system of California's Caregiver Resource Centers. But I'd like to point out that that system just experienced a 72% reduction in last year's budget. So that's a challenge, again, for the caregivers of our state. There's a couple of other programs that also offer caregiver assistance through programs such as the Alzheimer's Daycare Resource Centers. But again, those programs also experienced total elimination of state funding as part of last year's budget.
So wait, they just experienced a 72% reduction in
the Caregiver Resource Centers did, yes.
And so, I mean, that's a big number. But what's the impact? They're reducing staff. I mean, is a lot of the information they provide online?
That varies across programs. There is, however, through the Department of Aging, they have National Family Caregiver Support Funds that come from the federal government. So they work closely with the state's other caregiver resource centers to try and help maximize funding to the extent possible.
Yeah, but again, I just want to make sure I understand what's the real impact. I mean, I understand the number of 72% reduction in budget. Whenever you hear reduction in budget, and I'm reading the materials, and we look at the proposed budget, we understand what that means. I don't understand it. I mean, in this instance, you're saying they get federal funds, but they're losing state funds. So what's the real impact of
Well, that's the question of the impact of the budget cuts is a very good one, and I think that's one that potentially can be discussed throughout the hearing today. It's a question that many people have: is how do you measure the impact of these cuts and what they actually will mean for the recipients? But one can assume that with all of these reductions, you would have caregivers who become more stressed and unable to provide the care to their loved ones, which could potentially lead to the likelihood of institutionalization for the care recipients.
Commissioner Anderson had a question, and then Commissioner Geller.
Yes, I got several probably. Your testimony kind of talks to, you left out one system, family support system and government support system. I want to say taxpayer support system, but I also think there's a charity support system that you really didn't talk about. As we move forward, and we have a country that's more unwilling to pay the high taxes, that tax support system is going to have lots of push and pulls in it. The one that most concerns me is that right now the senior population is by and large being supported by its families.
That's right.
The baby boomers didn't create a lot of family. And women, the baby boomer generation, have women who are not interested in caring for their families because they're in the workplace or doing other things, or they've waited so late to have children that their teenagers and their parents are bumping heads in terms of support. So we have, looking forward, we have a public who's not interested in paying more taxes for services. We have a charity system that is probably going to crumble when you can't get deductions for charity. And we have a family support system that probably won't exist in the way it has existed in the past because women aren't there to provide this support. How do you get to your model given those kind of constraints? That's my first question. The second question is, the caregiver system has always depended on people who are, less skilled. They're not necessarily people who've gone through 4 years of college or 2 years with an associate degree who wind up doing caregiver provider services. We have a society that is pushing for more and more people to be in the educated class, which says to me if we really reach that goal, there are less and less workers available to take care of these older people. So the question is, where do you find the workers to take care of these older people? Now you don't have families. The third piece of that, and this is for California mostly, it probably is in other states, a lot of the people who are becoming elderly are coming from the middle class, some from the lower class, but most of them of European descent. The people who are going to be the workers, by and large, won't be from European descent. So not only are we going to have a caregiver group that doesn't look like the group that we're providing care for. So I just see all kinds of frictions with that. Those are my questions. How do you solve those questions in your model?
You got all those?
I think I do. I think I do. Well, you've asked some really tough questions. I'd say in terms of how do you get to the system that's in these 6 elements, we certainly recognize that these are the ideals for what a high-performing long-term care system would look like. It is not anticipated that any system is going to be able to achieve them all to their maximum. And it's really about making decisions about where do you put the emphasis of your efforts, and in terms of policy and in terms of the resources available, what are the elements that are most important to you, and how do you develop those to their best in the system. And so I can't answer the question perhaps maybe in the way that you'd like to. It's really about laying out what are the ideals and allowing and for you to choose within that what are the things that are most important. And
I don't have a way for you to answer. I just want to know how you've considered these in your model. You know, you laid out a pretty, I think, idealistic model.
It is, yes.
And my view is that I believe that I'm only listing some of the realities that you're going to face. How have you guys thought about these impacts or possible happenings in how you're moving forward with your model and your thinking?
If money were no option, I think that would be your answer.
Of course, and
Money's always an option.
money is always part of the equation, and clearly with limited resources, you have to make the tough decisions, and you have to make the hard choices about which are the elements that you're going to focus on, which are the ones that are going to fall to the side, and that's that's why you guys have the tough job.
Isn't that the more important discussion to have, rather than what an ideal system would look like? Isn't it more important to have the discussion around what is the best system that we can afford, given the resources that we've got?
And this is real. What these elements are really serving as a guideline for having that conversation. Absolutely acknowledge that no system is going to achieve these to their maximum, because we are living in an environment of limited resources, and we recognize that. These are really provided as a guide in thinking about policy and how to focus policy efforts that may help to improve these elements so that it overall can reinforce a long-term care system.
Well, I want to comment on Commissioner Anderson's statement, which is, I mean, you're right. A lot of this doesn't necessarily, some of the things you said wouldn't appear, money isn't the issue. It's the changing focus on careers and occupations and just societal changes, workforce aspects. But again, I guess I go back to what the chair just said. What can we realistically achieve? You're right. If there are fewer people to take care of the aging population, which we see running right at us, it's a freight train. We can't avoid it. Right. What can we realistically achieve? What should we really realistically be focused on your 6 aspects? I mean, again, the resources to provide the care, the people to provide the care.
Yep.
People that don't have family.
Sure.
I read in the materials that long-term care, what made me think about it was long-term care policies probably should be a major focus, because we all get mailed stuff. When you work for an employer, you always get mailed stuff that says you should take care of your long-term care. I have to admit, for the most part, my colleagues and I, we always throw it away.
Sure.
Well,
but and this is a tough.
It's expensive.
It's expensive. It's an issue. Quite honestly, it's an issue that most people just don't want to think about. It truly. I mean, I think that's one of the realities here, is that long-term care is one of those things that you just generally in your day-to-day life don't want to think about. It's a reality, though. And certainly from a policy perspective, looking just at the demographic change that we're anticipating, the need to be prepared for a larger population requiring these services is going to be important. I would just point out a couple of things in terms of workforce. We know that the workforce is not ready yet to handle the demands that are going to be put on it.
It's not ready. It doesn't exist.
Well, it exists. It's just not available in the numbers that are needed for the population as it's growing, and it's also not available equitably across all geographic areas. And I think that's a reality. I would just point out to healthcare reform. The healthcare reform bill just passed. Is just signed into law, and there are elements of healthcare reform that will help to support workforce development and increase the number of individuals that are in the workforce, both physicians, especially physicians with specific training in caring for older adults and people with disabilities, as well as with the direct care workforce. So there are elements in the bill that will help to enhance and grow the workforce and improve the training.
Because maybe I didn't, obviously I didn't read the 2,100 pages of the bill, but nor did anybody in Congress. But when you make that statement, I just think I want to make sure we're, because people listening to this, will assume that, that there is some magic bullet in the bill, in the law, that now says we're going to be able to increase the infrastructure, the doctor infrastructure, and they're going to have better training. And again, with all the baby boomers that are retiring, we're going to have a better system and structure in place, which I don't see how that's going to happen right now you have a shrinking infrastructure of doctors and medical professionals to meet the needs that exist today. The medical reimbursement wasn't addressed in the bill. I mean, there are a bunch of things that weren't addressed in the bill. So how miraculously are we sprinkling, fertilizer on the system and it's going to grow and meet the needs of this population?
Well, I would certainly concede that the bill is not the magic bullet that some would hope it would be, and it doesn't address all aspects of the system. And it just is not. It was not designed to address every aspect. And so there are gaps to be filled. I think that it is a great place to start, that there are some really promising elements in that bill that will help to reinforce the infrastructure, the workforce infrastructure, improve training requirements, and start to build up that workforce supply in the areas where it's been lacking already.
But how? I mean, I'm not trying to be argumentative.
Sure.
I really believe, in reading this material, I'm more concerned now than ever about where we're headed as a state. And the health care bill was focused on an aspect of everybody should be covered. But even now, even you yourself just admitted that long-term care is a big concern for a population that's incredibly large.
Right.
And so nothing in that bill to my knowledge, really addresses long-term care.
Well, actually, there are quite a few elements. There are several elements within the bill that really start to get at long-term care reform. It's really opened up Pandora's box when it comes to long-term care reform, and really has started an important discussion. For one major element of the bill is that it includes the Class Act, which will make available it's a public long-term care insurance program that will be available to all working adults. And I think that this is going to be a really important program offering for the majority of consumers. It will be accessible to the middle class, and that it will offer for the first time in a broad way an ability for individuals to start planning for their own long-term care. And the details of it are still being worked out, and I'm not privy to those. But this is one opportunity that will allow it's not just focusing on those in Medicaid that are low income. This is really making long-term care more accessible to the middle class, and I think that's a really important piece of the bill. So that's one element of the bill that I think really opens up opportunities for long-term care and for making sure people are
So
are prepared.
it's conceptually mentioned in the bill, but the details.
Well, some of the details are in there, and a lot of it is going to be
Somewhere
worked
in
out
those
in the
2,500
implementation.
pages, there's got to be some details.
But you honestly, in your heart, this is what you focus on. You believe that what's in the bill today takes an aggressive and an appropriate step forward on this topic, or
I believe
is
it's
a nice
an appropriate step forward. I don't think that is. I would like to see. I would like to see it go further, but that is.
But it has to be paid for.
But I would say that if you looked a year ago when the healthcare reform debate began, long-term care was not even on the radar screen. And to see where we are now, we have some really important elements of reforming the system, of developing and implementing some demonstration programs that will help to see what are the things that do work that help to increase access to high-quality long-term care, and that can enable people to remain in their community and in their homes, which is their preference, and make the financing for long-term care a shared responsibility, not just that of the governments. And I think those are really important elements, and there's much more work to do. But this is, given that we started out with a year ago having nothing there, to where we are now, where there are many elements that reinforce the workforce, that give options and access to long-term care for people in the middle class that did not have real options before, and are testing out new ways of providing services. I think that's really an incredible and promising direction. Okay. And we have more to learn there.
I want to let Commissioner Anderson make sure she got her questions asked or finished, then go to Commissioner Geller. Okay.
As I was reading this, in the background there was all the discussion of health care and where the bill was going, and I had a hard time reading this, listening to that, because I didn't know how it would weave together, and I'm not sure anybody knows how it weaves together in this particular. It sounds good, but I think it's
devil's in the details.
That's exactly correct.
Okay, Eloise, and then
Okay.
And then, do you have a question after that, Marshall, or are you kind of you okay? And then we'll go to Ms. Steenhausen, have the floor. So start with Commissioner Anderson.
I have two issues. One is that we override this program, in-home long-term care, with medical services. I don't like to call it health care because I don't think that's what it is. I think it's providing medical services. So medical services drives it. But to me, understanding this program, the larger component is the social model, which you really haven't talked a very much about. And what I know about human beings, the social model may be the most important part of the model. And I don't understand how the social model works here. What I hear is the medical service model. And what I'm concerned about is for people who are disabled, because this is not a disabled program, this is a senior program, and some who may be disabled. But there's also another whole big issue out there of young people who are disabled, who are not seniors. But the social component seems to me to be the underwriting factor of how we live in community, how we live when we are isolated, particularly the elderly. We die earlier than we would if we're not in isolation. So to me, how are you looking at funding the social component? Because in reality, the medical service component has been manipulated to support the social component. And I suspect over time, as resources get more limited and taxpayers get more tired of most of their income going to pay taxes, the social component will not be funded. So where do we go with that piece?
It's a very you are asking the very challenging questions, and we have to work to reinforce the supports that are available and make the tough decisions within a limited number of resources, make tough decisions about where those resources will go. I don't know if I have a real answer to your question at this point, to be totally honest with you.
Go ahead, Ms. Dean.
I think also it's going to be, this discussion is so important to have, and it'll be really helpful to hear from some of the other panelists, specifically from Dr. Hendrickson, who's going to provide an overview of the recommendations that they've laid out as part of the long-term care financing study. And they're really looking at ways to maximize the use of resources in the long-term care system to help promote access to home and community-based services. So I think a lot of these questions will start, maybe perhaps there'll be some additional ideas that are raised and issues that the Commission can consider.
Okay. Ms. Steenhausen, is there any part of, we kind of been all over the place, but let me give you an opportunity to tell us the things that were part of your testimony.
Sure. Thank you very much, Commissioners, for the invitation to be here today. Again, my name is Sarah Steenhausen, and I'm a Senior Policy Fellow with the SCAN Foundation. What I really want to focus on at this time is to provide you with a general outline of what are the main challenges that California's long-term care system faces, as well as past and current efforts to address these issues. I hope I can leave you with a context from which to evaluate potential options for long-term care reform. It's widely known that individuals prefer to receive long-term care services in the home and in the community as opposed to moving into an institution. This preference is affirmed by the United States Supreme Court in their ruling in the 1999 case of Olmstead versus LC, which says that individuals have a right to receive care in the least restrictive environment, and that states must take certain steps to provide home and community-based services as an alternative to institutionalization. California's home and community-based service system was established out of a movement that began in the 1970s and spawned a number of innovative programs that served as national models for care, including the In-Home Supportive Services Program, which is a consumer-directed program that provides personal assistance services to individuals in their home and in the community, as well as the Program for All-Inclusive Care for the Elderly, or the PACE model, which is a national model for an integrated services delivery system. The Adult Day Health Care Program was also first established in California. It's a community-based day program that provides a variety of therapeutic, social, and health services to individuals at risk of institutionalization. Finally, another national model of care that was established here in California is the Alzheimer's Daycare Resource Center program. There are a number of other programs and services in California. Those were outlined in the program compendium that we submitted as part of our testimony. I think it's really important to recognize that the state was once seen as a national leader in the provision of home and community-based services. But despite these advancements that have occurred over the past 30 years, the system today is plagued with fragmentation, a lack of system-wide data, capacity issues, and fiscal pressures. Many of these issues are the same issues that the Little Hoover Commission addressed when it came out 14 years ago with its thoughtful vision for long-term care reform in California. Unfortunately, those recommendations that were outlined in the report did not come to fruition, and today the state is continuing to struggle with many of these same issues.
Not the first time they ignored us.
Well, I think there were several efforts following your report, however, that were an attempt to provide some of the implementation of some of the recommendations you laid out, but for various reasons did not come to fruition. Right now, what I want to do is address each of these challenges in a little more detail to leave you with a sense of why reform is critical and perhaps where some opportunities may be. So the first challenge that I would like to address is our fragmented service delivery system. I think many people have heard about this issue. This is one that was highlighted in your report 14 years ago. And what we have seen is that while there are several important home and community-based services programs across the state, program development and expansion has occurred in silos and without an overall system strategy. The programs have grown out of different funding sources, different oversight entities, and different eligibility requirements. All of this translates into tremendous fragmentation, which, to Lisa's point, does not lend to a person-centered system of care. There have been many attempts to address this system fragmentation by integrating the funding and service delivery across the long-term care service system. But the complexities of integration have prevented these efforts from gaining the necessary stakeholder support that was needed for implementation. Other efforts to address system fragmentation have focused on consolidating the state administrative structures. The idea was to allow for more coordinated programming, data collection, and policy development. The proposals were not adopted for a number of reasons, including fiscal costs, as well as questions as to whether consolidating administrative structures would actually lead to improved care and coordination for the consumer. The second issue that I want to highlight that challenges California's long-term care system is a lack of capacity. Specifically, not all home and community-based service programs are available on a statewide basis, nor are they all funded at a level that can adequately serve every community in California. As a result, some programs have long waiting lists and aren't able to serve all of those who need services. A great part of this problem can be attributed to the federal Medicaid, what is called the institutional bias. What this means is that the federal law provides an entitlement to institutional care and requires states to cover the cost of nursing home care, but it does not provide a similar entitlement to home and community-based services. This means that there is no guarantee that individuals can access services in the community when they need them. It is important to point out that there is one service system in California that does provide an entitlement to home and community-based services, and this is the service system serving people with developmental disabilities. The basis of the Developmental Disabilities Service System is grounded in the Lanterman Act, which is established in statute and expresses a commitment to serving people with developmental disabilities in the community through regional centers. Yes.
The institutional bias is because it's a medical service bias. The developmentally disabled has an underwriting viewpoint or theory or ideology is that it's not all medical. It's also a social model. So when you talk about, we're going back to my question about the social model. But everything I'm hearing you ask for is the medical service model. So if you want a program that looks like the developmental delayed service, the regional centers programs, you have to move away from the medical model as being the driver. And it seems like there's a reluctance to unhook ourselves from the medical service model and move over to the social service model for fear that it won't be funded. It might not be. But it seems to me that the continuing to want to put our hand in the medical service pot to support this puts us in a bind. Okay.
Well, these are very important points, and I think maybe just to clarify, when I speak of home and community-based services in the community, those are the range of services include social services.
I know it does, but I'm just saying when you said the federal program has an institutional bias. It has an institutional bias because it's a medical service model.
Right.
And then you juxtapose that against the developmental system, which I don't believe has a medical service model. It has a social model. And I'm just suggesting that you got to be clear about what you're asking for here. Okay.
Certainly, and my mention of the developmentally disabled service system is not to say that that's what we're as a foundation asking for. It's to point out that there is one system in California that does provide an entitlement to these services. And what it's actually done is it's provided a single entry point system where there is a coordinated access to services across the continuum, including home and community-based services, social services, as well as the more the institutional level of services. But this is unique in comparison to the broader home and community-based service system that does not provide as coordinated access to these services. So if I haven't answered your question, please.
No, you have. I want us to be careful about how we portray things, because I think often when we do that, and especially when you use a system that is, to me, is a social model system against one that is a medical service system, people don't understand those differences, and I think we get people going down a path that is physically unsustainable.
Okay. I appreciate that.
Okay.
Thank you for that. The third issue that I want to highlight that presents challenges to the system is a lack of fiscal incentives to promote home and community-based services. For example, in-home supportive services, through the in-home supportive service program, counties are responsible for a portion of the share of cost for each individual enrolled in the program in that county. But if that same person then moves into a nursing home, the counties are no longer responsible for any portion of their costs. So counties have no fiscal responsibility for institutional care, but they do for in-home supportive services. Ultimately, this leaves little fiscal incentive for counties to promote home and community-based services over institutional care. The fourth issue that I would like to highlight is the lack...
And that's a concern.
Well, it's a concern because if you're in an era of the fiscal pressures that we face, and if you're looking at ways to promote access to home and community-based services, it's challenging when promoting home and community-based services at the local level, in the case of in-home supportive services, costs counties more money, but it doesn't cost them more money to place individuals in a nursing home.
Well, sure, but if you're a county right now and you're waiting for the state to make final decisions on the health and human services budget, which is moving in the wrong direction, no county is. You're not surprised that counties aren't looking.
No, this is just laying out that it's a reality that there is no incentive fiscally right now at the county level to promote and expand access to home and community-based services.
And again, I don't know that there ever will be. Do you expect that there will ever? I mean,
yeah, I think that's something for the Little Hoover Commission to look at. There's a number of different recommendations that, as I said in the long-term care financing study, some other states have instituted what are called global budgeting systems, where they're able to combine all of their long-term care budgets into one pot, so that you can do a better job of capturing some of the savings from some expenditures and using them to promote access to, say, home and community-based services. Actually, what I would like to do is have my colleague Les Hendrickson answer those questions. I'm not as familiar with the details of that, so I think that would probably be more appropriate for him to answer, if that's okay. Okay, so the fourth issue that I'd like to highlight is the lack of data and system-wide planning. There's no single department or agency in California that uniformly collects and reports all long-term care data. Without this data, it's difficult to evaluate program effectiveness and identify needs and gaps across the system. There is an effort in place that's in the process of analyzing and reviewing all home and community-based data in the state. This is a project that's supported by the SCAN Foundation in partnership with the California Department of Health Services and the California Medicaid Research Institute. This research will provide information on cross-program utilization as well as the cost-effectiveness of services. But again, the problem still remains that across programs you have a lack of uniformity in how data is collected and what is done with that data.
Can you provide the commission with, doesn't have to be today, but soon, what information you want in the data collection? Specifically, what kinds of information are not being gathered now that you would like to have? What questions that you would be asking?
Okay.
Thank you.
Sure. We will be happy to follow up with you on that issue. The final and most critical issue facing the long-term care service system right now is the state's fiscal crisis. Recent reductions, both those already implemented and those proposed as part of the governor's budget, continue to threaten the system's infrastructure. And just as an example, under the governor's proposed budget, support for home care under the IHSS program would be reduced to levels not seen for almost 30 years. The governor's proposed budget would reduce the caseload by 87%, and this means that only 13% of current recipients would continue to receive care under this program. Another program hard hit by the fiscal crisis is the Adult Day Health Care Program. This year, the governor is calling for total program elimination, which would impact approximately 37,000 service recipients who are at risk of institutionalization. Additionally, programs established under the Older Californians Act have also been hard hit. Last year's budget cuts eliminated state funding for the Linkages program, as well as other community-based programs such as the Alzheimer's Daycare Resource Centers. In addition, the state's system of caregiver resource centers, this is what I alluded to earlier in my presentation, were cut by 72%. These programs are the only caregiver resource for low-income families who are not eligible for Medicaid. So for many seniors and persons with disabilities who rely on all of these programs and services to keep them at home, continual program erosion increases their likelihood of institutionalization. And second, for the program providers, the gradual loss in revenue may cause them to close their doors. Taken together, these cuts threaten an infrastructure that has taken more than 30 years to build in California. What California really needs right now is system reform, not system reversal. So today, it's just as crucial that the state address the challenges that the Little Hoover Commission laid out a number of years ago. But it is important to recognize that there are a number of efforts that are currently going on in the state to try and address these challenges across the spectrum. These are important efforts, and many of which you will hear about them today. But what is missing is an overarching system-wide plan or a strategy that lays out how the state will develop a more person-centered, high-quality, and efficient system that ensures care for all who need it. Ultimately, what California really needs right now is a roadmap for reform, a strategic plan that would set priorities for services and that would develop specific, measurable action items and a plan for how to meet those goals. The Little Hoover Commission is in an excellent position to support the development of a roadmap for reform. Thank you very much, and I am happy to answer any questions that you may have at this time.
I don't know. What is Medicaid eligibility number?
The Medicaid eligibility number? I'm not sure I understand the question.
I mean, like you said that many low-income family members are not eligible for Medicaid. What's the cutoff? I don't. 130%,
I believe it's going up to 133%.
Of federal poverty level.
I think Megan, who will be coming, and Lynn, who will be coming to speak, that they'll be able to answer the exact eligibility criteria.
We could always follow up if you'd like.
I just want to know what it is. With all the discussion of the Medicaid expansion in the new bill, what's the Medicaid? And there were references that some people are eligible for both Medicare and Medicaid.
Correct. So you have they're commonly called dual eligibles. Those are individuals who are eligible for Medicare, either because of they're age 65 or older, or they have a disability, and they're eligible for Medicaid because they're low income. They qualify under low income.
So, Eloise, I mean, how you dealt with this? I mean, how I don't know why is there dual eligibility? Is it just a necessity because Medicare won't cover everything?
There's limits on Medicare and there's limits on Medicaid, and you can put the two of them together and get more services than if you didn't.
So
It's an income issue.
But so now so that means that the baby boomer population is going to make that dual eligibility situation grow?
There is the possibility that some individuals who age into Medicare will be low income and will become eligible for Medicaid.
And if you expand Medicaid to higher brackets of income,
yes,
you're going to have more dual use.
That's correct. And really what Medicaid is offering for those who are dually eligible, so Medicare covers medical services, hospital, physician, outpatient care and such, skilled nursing care. And what Medicaid is offering in that case is sort of wraparound services that cover some of the cost sharing of Medicare, as well as some additional services that Medicare doesn't cover, some of which that have been cut in the
Well, it covers
Medicaid
covers institutional long-term care services, such as those provided in a nursing home. And then, as I was saying, the limited home and community-based services not limited, but the home and community-based services that each state choose to offer. Again, it's not an entitlement.
Different cuts. The one program, you have a shared cost between the federal and the state and in the counties. The other one, it comes out of Social Security cut, where people have actually paid into it. So you get really two different funding sources here, maybe three, that they've merged together here when you do dual. So on this one, there's no state share. That's the Medicare. There's no state share over here. There's a state share. And as this piece, the eligibility goes up, there's going to be more and more of a state share in here. So there's a big state hit on the increase here.
Except in Nebraska.
Actually, that was removed from the bill. So
It hasn't
Have
been,
they got it out?
It hasn't been removed
No, it
yet.
hasn't been removed
It has
yet.
not been removed yet.
Oh, that's true. It
Yeah.
has not been removed yet,
Yeah.
but the plan is that that will be removed.
Won't be removed.
It-
We went through that yesterday and
Yeah.
it was refused. So without talking about the bill, just talking about
So, but I guess the question then is this dual eligibility issue. I mean, this again points to the concern about where we're headed as a state.
Yeah.
You're going to have a larger population that is retired, that is in need of both of the services from Medicare and Medicaid.
Yes.
And as Commissioner Anderson said, again, it comes down to you're going to have to fund this somehow. And no one's really thought about, I mean, again, if the state's portion of what they have to fund increases, I don't even know what the federal government's going to do. But is this is a more dangerous situation than
$2 billion hit at least.
Well, I think Stuart said it was 3. Would you say 3 to 4?
And they're going to spend months trying to figure out exactly how much.
It's a big number.
We've also got another issue with the Medicaid part because it's got county funding in it when you do all this in-home stuff. Is that the elderly tend to move from where they were to where their children are, wherever that is.
Wherever that is.
And so I suspect that because most young people are in big urban areas, you're going to have a movement out of the more rural communities into the urban areas so people can be closer to their children. So
The big cities are really going to take a hit. The big counties are going to take a really big hit.
You mentioned you did a rating system. Didn't I hear that in your testimony?
The long-term care scorecard. It's
Yeah.
actually a project that's still under
Tell
development.
me how we did.
Well, we don't know yet.
Oh.
So, as I said, this is a project that is still under development. It's still in the planning stages. The anticipation is that we'll have a baseline scorecard for all the states in the spring or summer of next year. So, unfortunately, we don't have that to share with you today. We're still working on, AARP Foundation is doing this project with funding from the SCAN Foundation and the Commonwealth Fund. They're in the process right now of settling on what are the measures that will be included, and they're being organized around these elements of a high-performing long-term care system.
Anecdotally, as you look at things and as you talk to your colleagues and other professionals, what's the sort of scuttle about who's doing a good job on this issue? What states?
Yeah, Washington and Oregon have done some really innovative things, especially in home and community-based services.
Pennsylvania is also
Pennsylvania is one of the early states to really be hit by this demographic shift towards an older population. It's one of the oldest states in the union, and so they've had many more years to try and grapple with these issues and trying to ensure access to long-term care services for their population. There are Arkansas has done some really interesting stuff with Money Follows the Person. They're one of the early states to implement Money Follows the Person. So there are examples across the country of interesting things, and I don't know. Certainly, some states have a greater imperative to answer to these issues at this point in time. When we get the report card, we'll be happy to share that with you, and that will give us a sense of where are states right now, and we'll be following that up again about a year after the baseline to understand, given the implementation of healthcare reform and other efforts that states are endeavoring to put in place, how things have changed in these measures that we're including in the report card.
Is level of funding one of the criteria?
It is, yes.
Well, we have to compare ourselves against Texas, Florida, and the big states that have large senior populations.
That's right. And the measures will be appropriately adjusted for differences in population and such. And that's being attended to in the development of the measures that we'll be tracking.
Okay. I'm going to recognize Commissioner Anderson, and that'll be our final question, and we'll move on to the next panel.
In looking at states that provide a better system of services for long-term care, is there any pull? You know what I mean by pull? You got a good system, I'm living in this state. I like what you're doing. I'm moving to that state. Is there any notice of pull going on?
Not that I'm aware of. I think if you will, the migration issues for seniors, they differ, and I don't know that they necessarily depend on the programs that are offered. Certainly, you see a migration of seniors to Florida, to Arizona.
It might be weather.
And that, well, that's certainly part of it. And you see they call them the snowbirds,
Right.
those that
Right.
travel down to the warmer states during the wintertime and then return to their homes, their home state in the summertime. And so I don't know that any one particular state is a draw simply because of the programs, the services that are offered there. Thank you.
Thank you very much for your testimony. We appreciate it, and hopefully we can continue to be in touch.
Wonderful. Thank you very much.
Stuart, you call our next witness,
Yes, our
please?
next witness is Mr. Leslie Hendrickson, who will discuss recommendations to improve access. Mr. Henderson is the principal of Hendrickson Development, a consulting firm that specializes in long-term care solutions. He also co-authored the report, Home and Community-Based Long-Term Care, Recommendations to Improve Access for Californians, which is being very deeply read around town today. Prior to his consulting work, Mr. Hendrickson served as an assistant commissioner in the New Jersey Department of Health and Social Services. Good morning.
Good morning.
Welcome. Thank you for attending. I like the seal on your testimony, so that turned out nice. So.
Looks good in color, too.
It does, yeah. Proceed.
I thank you for the invitation to present comments today. Bob Malika and my colleague and I appreciate the opportunity. The Commission has a long history of publishing great reports and being influential. In fact, a California friend of mine told me that the Commission is so well known that they named a large dam and a popular vacuum cleaner after it. I was asked to address 4 topics. An overview of the findings and recommendations. I think staff provided an executive summary, which really is the best overview, but I thought we might at least say how we did the work. We first just read everything we could about California, and we found pages of studies, including the work by the Commission. We also did stakeholder interviews throughout the state. We probably went to 4 or 5 places. We listened to hundreds of people talk about long-term care. We interviewed staff in departments. We reviewed computer records. The report itself had a long review process. We had over 35 commentators. They worked on it for we dealt with 6 months of comments on it. So that's kind of how the report was developed. I was asked to address how long-term care efforts could fit more seamlessly, and the Commission well knows some of the answers to that. The 1996 report was excellent. The 2004 report on real lives, real reforms, also spoke to these same topics of long-term care. In 2006, the California Healthcare Foundation did a 10-year review of the 96 report and said that progress had been limited. And for example, there was some progress around the establishment of public authorities for IHSS and some single points of entry. Recommendations for consolidation and reorganization have not occurred. And discussions of long-term care reorganization, like discussions at the Mad Hatter's Tea Party, have been interesting but have not resulted in Alice finding a way out of Wonderland. And in my humble opinion, if reorganization of major departments had been possible, it would have happened by now. There was no consensus among the people we interviewed about what that reorganization could be. For example, small departments are kind of worry about consolidating with larger departments, lest their missions get lost in the larger department. Advocates are also wary of changes, preferring the devil they know rather than the devil they don't know. And so instead, the one of the sort of implicit themes in our report was not to really focus on the consolidation of departments, but to look for other ways, kind of at a more medium kind of strategy on how long-term care could be organized. And Senator, I want to just say, Senator Liu's bill, 998, is really an outstanding bill. If you look at it, it has really two main themes. One, the need for assessment and the need for case management. And those are really characteristics of states that have organized long-term care programs. And in fact, you can, the latest health care bill, 3590, that we've all been talking about, that we've seen in the papers, if you look at the long-term care section of it, in Title II's Subpart E, if you go through those 5 or 6 sections, you could see how well they fit with the kinds of themes that, these federal themes on how long-term care should be organized, how well they fit with the kind of the approach taken in Senator Liu's bill. It is a we frequently hear that long-term care needs to be person-centered, and I want to just elaborate that a little bit. There is out of the rhetoric of the disability movement some 10, 15 years ago that came the concept of person-centered. And indeed, the feds then began to open up some person-centered, self-directed kinds of options in Medicaid. But from a management standpoint, a person-centered program is a program where you have data organized by persons, not necessarily by organizational units. And I present an unintelligible table in the back of my testimony that is so small you can't read. But my purpose isn't to have you understand the kind of each number or each word on it, but it's the concept of it. And what you're looking at is a study by North Carolina on case management. And what they did was they had the awareness that they were paying for case management in more than one program. And so they did a study. They looked at every time within a 60-day period where they paid for case management, and then just plotted out what program, for that we're talking about the same person, what program that person got paid under. And so the column, the programs in the column are the same as the column, or are the same as the programs in the rows. And what it just shows you is the same programs of how people are getting paid for case management. And so if you're only thinking about one department or a couple of programs, you miss the fact that you're paying for the same services in all these other programs. And it's not until you organize your database and your programs on a person basis, where you're collecting information on a person level that spans programs, do you actually begin to understand what it is you're not managing. See, as I see the issue, or at least one issue, is that unless you have that kind of database or that kind of control over your programs, you don't even know what it is you're not managing. In this case,
who's got that?
Well,
that kind of database that they can do that.
Well, Oregon and Washington have it. There are some other states that have major hunks of it. Pennsylvania's doing well. You see an example from North Carolina. And I want to talk about a database, too. I know that folks tend to say, God, a database, who has that kind of database? But on the other hand, this week I had the experience of flying on Continental Airlines, which has a massive database, and it keeps track of thousands of people flying every day and your frequent flyer miles and the crews that come and go. I stay at hotels here that have these huge databases that keep track of every time you've stayed in their hotels, all your future reservations. I went to a Walmart on Monday, and I learned from CNBC that within 15 minutes after you buy something at Walmart, it gets uploaded to an inventory control system. That, when the store starts, I buy a toothbrush, if too many other people buy toothbrushes, that inventory control system connects with a local warehouse that mails the store a box of toothbrushes.
Marshall, you turned your mic on.
There's profits involved in those things. You make money. can't see where anybody's making money here. I mean,
let's
you have to have profits in order to make those type of things happen.
Well, California long-term care is not a mom-and-pop operation. I mean, on the one hand,
It is a mom and pop.
The state is spending $8 billion a year on their long-term care programs. And even after you cut huge hunks out of the system, you still have you have billions of dollars that the state is spending. And if you're going to be spending that kind of money, you have to have information systems and technology that can support it. I mean, a state that gave birth to Hewlett-Packard in its garages and Google in its educational institutions surely can build a better database for long-term care.
You haven't read our technology report.
Yeah, you're preaching to the choir. Commissioner Anderson.
Okay.
Commissioner Anderson had a question.
I understand what you're saying, and I think that the problem I see is the notion, and I'm going to go back to my basic statement, case management comes out of the medical side. And so we believe that, the case record in the hospital, so the whole notion of having a case manager is following that medical model side. If you want to do what I think private business has done, I think we may need to walk away from that and say, how do I make sure that she's getting all the services she needs, which is a different model than looking at a case management. Then I would be saying I'd put a very different kind of data system together if I drive it around her as a person rather than me as a case manager trying to look at things within my program. And I think it's within my program issues that are causing the duplication all over the place. And I don't know in government if there's any incentives to get rid of the in my program approach to collecting data. So that's really a question statement.
Okay. Also, a person-centered system tends to have reimbursement that's specifically more tailored towards the person's characteristics rather than the provider's characteristics. Medicare has been the biggest promoter of these systems over the years. So they, for example, in nursing homes, they use a long assessment instrument to call the MDS, the minimum data set, and they break the population into some 44 different groups, now expanding to more than 50 groups, and then they pay based on which group you're in, based on how that assessment instrument is done. So it is also a not something that California does generally in its reimbursement, but again, it's a kind of a more person-focused where you try to set a reimbursement rate down so you're paying for a rate that's characteristic of a person that you're paying for. Okay. So getting back to the theme of like what do you do if you don't have a lot of money, what kinds of things can you do? I think that you can build organizations that span departments. If you can't consolidate departments, then build an organization that spans different departments. And a really good example of this is Pennsylvania. The services are being offered in two different departments, aging and public welfare, and it was hard to figure out. You can't consolidate them, apparently. So what they did was they built an office of long-term living. They got a deputy secretary, and they made him a deputy secretary in both departments and gave him the responsibilities that span both departments. And I think that offices and units within departments are only building blocks. That's all they are. And you can arrange, in California, you can arrange those building blocks any way you want, except on alternate Fridays, of course.
Alternate? 3 Fridays.
3 Fridays now.
I think Commissioner Brewer had a question.
So the Agency for Longer Living, were there cost efficiencies? Were there cost savings as a result of that? Or was it merely another level of bureaucracy?
Well, it wasn't actually another level of bureaucracy because they still have the same staff they had before. They just combined them in a different way. So they didn't lose staff and they didn't gain staff, but what they did was they got a better coordination of those services. Pennsylvania is a really interesting state to look at in terms of its long-term care program. It's a large state, few states are large compared to the country of California, but nonetheless, it's a state that has a lot of lessons for California, I believe. Another kind of more local level of organization, and that we've heard some references to, are the Aging and Disability Resource Connection Program. California has 6 of them. You can see the emphasis on this in the new federal legislation. It sets aside another $10 million to expand that program nationally. The new, for want of a better phrase, I'll call it the Obama health care plan, just because that's the usual way we see the headlines referring to it. But that's, again, a program that's clearly favored at the federal level. It's recognized as being of a lot of use at making local coordination possible.
I have another question for you.
Sure.
In your comments, you said that California needs to do a more rigorous job of maximizing federal revenue. Would you expand on that?
Could I get to that in just a little bit? I was asked if all the state's existing programs should continue the way they are. And unlike the intelligent foreign policies followed by Iraq and Afghanistan, California did not declare war on the United States and thus has lost the billions of dollars in economic aid and the benefits of building numerous military bases. And so California has a 3D IMAX budget deficit. And it seems to me that state policymakers are in a position where it's difficult to cut programs because you're immediately in court, and yet you can't add programs because you have so little budget resources to do that. And what is it? What is it in this environment? Is it reasonable to do about long-term care programs? Now, speaking of Alice, we know what the Red Queen would do at this time. But it does seem to me that we can focus on administrative efficiencies and planning. This is a great opportunity to plan and to take administrative actions that are cost-effective and might have a payoff. And I think the state can become more efficient at maximizing federal revenue using provider taxes, using upper payment limits. California came late to the use of provider taxes. So there, I don't want to elaborate at length on what those Medicaid funding mechanisms are. There's various discussions of them, but I think I'm going to just kind of go on to make other points. I think that there are clearly some costs in the system that have been growing. They're expensive and have been growing pretty rapidly, like ventilator costs. It needs to kind of track down what those are, figure out what's going on in those areas, and do something. There are existing funds that are being spent that it could be reshaped more efficiently, I think. And the labor-driven operating allocation is like one of those words we all hear and immediately forget because we have no concept of what it means. It's not self-evident from the title. But now no one in California thinks of it like this. And none of the national literature describe it, but I think California has the largest pay-for-performance program in the country around nursing homes. Yet no national studies of pay-for-performance programs include it. Yet if you look at this thing called the labor-driven operating allocation that's in AB 1629, if you just go in the spreadsheets and you calculate the per diem that gets paid and the number of Medicaid days, I came up with 168 million. It is a massive program, and folks tend to think of it as a reimbursement of labor costs in nursing homes, but that's incorrect. It's not. The labor costs get reimbursed, but the labor-driven operating allocation is a bonus payment. It's an incentive payment, and it incentivizes the homes to hire staff rather than use contracted staff. And that's the only incentive in this massive $3.5 billion plus nursing facility reimbursement program that the state has. Now, if you look at what other states do, and I've coincidentally, unfortunately, I've had an opportunity to do that. In June, I was on a panel of folks who looked at pay-for-performance applications from Colorado nursing homes. We studied what other states did. It's, other states are reimbursing culture change. Like the new federal law has a demonstration project for nursing homes in culture change. They're reimbursing staff retention. They're reimbursing consistent staff assignments. They're reimbursing occupancy. They're reimbursing quality of care. But no one else in the country spends any money reimbursing hired staff versus agency staff, except California, and nobody spends the amount of money on this one performance measure. Everyone else spreads that money over more than one performance measure, usually 6 or 7 or 8 or even 30 as in the case of Colorado. So I think then that money could be spent more efficiently, and it's really a large amount of money. And I would just urge folks to take a look at it. And of course, if you decide to change it, it still goes back to the industry, but within the industry are winners and losers, so it's awkward for the industry association folks to deal with the topic. But nonetheless, it is an incentive program, and I'm just not sure it's incentivizing the right things. In our report, we also talk a lot about, I'm switching now to the next point, on nursing home transition programs and hospital diversion programs, or the classic distinction is transition when you help someone leave an institution, diversions when you try to make sure they don't get into the institution in the first place. California does have a transition program. It's been growing in the last few years. It's slowly expanding towards a statewide program. What we note is that there are other states that simply have just larger transition programs. This is a cost-effective program. Pennsylvania reports saving over $200 million over its last 5 years in its nursing facility budget from its transition program. That's what Pennsylvania staff told me. We think that a transition program should be substantially expanded. I'm not talking 15 or 20%. I'm talking 300%, 400%. I mean, that it is a cost-effective action, and that it's an administrative efficiency that I think you guys might want to take a look at in figuring out how to strengthen and help the existing program in California. In our report, we talk a lot about the cost-effectiveness of waivers and the need to study them and understand them. Right now, I think I guess my opinion on waivers is slowly changing. I think the state probably gets more bang for its dollars by consolidating waivers. If you want to, for example, rather than have a brand new separate TBI waiver, as has been talked about and legislated about, it might make sense to fold TBI services into an existing waiver and try consolidating waivers. And the issues here are really the administrative inefficiencies from having a lot of separate waivers. The feds over the last 5 to 10 years just keep adding more and more administrative requirements on how waivers are to be done, and that's been been taking place a lot in the last year. So it's a lot easier to provide kind of normal, regular state plan Medicaid services because you just don't have the administrative overhead of justifying the assurances to the feds. So I think the concept of waivers is good, but I think you could get administrative efficiencies by consolidating them. And the feds will let you do consolidated waivers too. Yeah. They're encouraging that.
Commissioner Anderson had a question.
Yeah, I'm always leery of the Fed, so please help me here. The more we buy into getting federal reimbursement, usually with the more we expand our programs. And then we can't leave them. So as we go get more revenue, more waivers, more whatever because we're trying to really push costs to the feds, we've also expanded our programs. How do we walk away from this? Which you just answered it. Okay.
Well, yes, that's the $64 question. I mean, once you start in your basic Medicaid program, once you start expanding those FPL levels up and keep adding new groups, it gets very hard to unroll them back to lower levels without some significant problems, for sure. Yes. There are really just basic licensing issues. Like the adult day health care that you folks identified in the little Hoover report way back when we did our public forums, we got complaints from folks about those licensing issues, and it's not clear why time and attention hasn't kind of dealt with that, but there probably are just administrative efficiencies around issues like licensing that would benefit providers and make it easier for them to do business with the state that are kind of have been long recognized and never quite dealt with. And finally, I just want to say that there are continuing issues that impede people's understandings of programs, and it would be more efficient if they could be cleared up so we could at least think more clearly about them. Fraud and abuse in the IHSS program, for example. How much is really there? I mean, is it a pot of gold at the end of the rainbow, and if it wasn't there, you could get a lot more money, or is it just a leprechaun's tail? And I think that so that's one sort of issue that, to the extent that steps could be developed to kind of resolve that, measure it, study it, determine it, get a better handle on it, because I'm in the gym 3 weeks ago listening to CNBC, and I'm hearing a gubernatorial candidate from California say that there's billions of dollars in fraud and abuse in the IHSS program that could be taken out of it, and it's really hard to plan for the program when you have those kinds of issues that are still lingering around it. Ditto around the issue of are waivers cost effective. I think you could just study the waivers to determine if they're cost effective, and some of that is now being done. I believe we've heard a study from the SCAN Foundation that will be addressing some of those issues. But to the extent that those things are cleaned up, it makes it easier to figure out what good policy should be around programs. Finally, our report did contain a number of what I call like process recommendations, like it's more efficient to let people who are in institutions have more than $209 as home deduction, because the idea of the home deduction in federal law was to help encourage people to leave the institution to maintain their home for a period of time, at least up to 6 months, so that you could decide, can you return to your home? And when you take all their money away and only leave them $209, then you're really kind of foreclosing that option or shutting it off. And so there are these kinds of some procedural issues like that we thought would be more cost effective if they were changed. And lastly, I was asked to speak about the state strategic plan and what it might look as our report recommends it. Now, on the one hand, we already addressed it in the report, and so Bob and I weren't quite sure what I should say today. The report states the plan must cover all agencies involved in long-term care, use a cross-agency perspective, should maximize input from people associated with the programs. Now, when Alice asked the Cheshire Cat, please tell me which way I ought to go from
Johnny
here.
Depp movie like about last month or so?
I didn't get to because it was so full that we got turned away. But it did want me to go and read Alice in Wonderland.
I've ever heard.
Okay. So when Alice asked the Cheshire Cat, please tell me which way I ought to go from here, the cat told her, well, that depends a good deal on where you want to go. And it seems to me that kind of captures some of the essence of a strategic plan. A plan, and I know that almost everyone here is really familiar with private business practices, and you have plans in your business, and a plan outlines specific steps you're going to take, who will undertake them, when the steps will be taken, what kind of outcomes you expect of those steps, and it usually has a shorter timeline of like 1 to 2 years, so it's some practical blueprint as to what kind of resources you're going to use and how you're going to do them. And I think that a strategic plan for long-term care is something that would pull together the various agencies involved in long-term care and make decisions as to what they need to do given the budget, given where they are right now. What is it reasonable to do in the foreseeable future? State units on aging have these plans. There are a lot of examples in the literature of them. They're generally pretty practical things. They're measurable stuff. We're going to add 40 people to our Medicare counseling program on the telephone line. Try to get 40 more volunteers. Things like that. So we think that there does need to be then a management by one program. And I'd also like to just mention North Carolina. They did a really interesting RFP recently for a business process redesign of the long-term care programs, where they actually want a contractor to come in and take them all as a single whole and then look at them together and how they mesh and just what they're doing. And that's the kind of thinking that we would at least recommend that the states use.
In the strategic plan that you just mentioned, this is sort of a theoretical question, but are you advocating the plan we want or the plan we can afford? Because in all these strategic plans, I see great plans, but the chance of implementation to me is remote.
I mean, in my humble opinion,
they create a system that is unachievable given the foreseeable resources. And, I think you've got to, my own judgment is you've got to have a plan that is viable and realistic and then scalable depending on how your resources come in.
I'm in 100% agreement with the chairman on this. I mean, you have to kind of start from where you are and what you can reasonably expect to accomplish and then accomplish it.
Any other questions? Thank you, sir, for your testimony. We appreciate you coming. Oh. Do you have a question, Stuart?
Well, I'll follow up later.
Okay.
It has to do with, do you start with a model or do you start with a plan?
Okay. Okay. Call our next witness, please.
Our next witness will speak from the perspective of the California Department of Aging. It's Lynn Dauscher. Good morning. Was appointed director of the California Department of Aging in 2007 by Governor Arnold Schwarzenegger. The department has program oversight for approximately 200 adult day health care centers and 56 Alzheimer daycare resource centers and administers a number of programs that serve seniors. Previously, Ms. Dauscher served in the California State Assembly representing the 72nd District in Orange County. Good morning.
Good morning.
Welcome, Ms. Dauscher. Thanks for coming.
I am my voice is, I'm a little voice challenged, so I will lean very close to the microphone. I've kind of changed my testimony listening to your questions a little bit. I think it's important to know that In California, the social side, which Commissioner Anderson has brought forward, the departments who serve who do home and community-based services include the Department for Developmental Services, which we've already talked about in terms of the regional centers. They provide home and community-based services. A rehab department, they provide oversight for the independent living centers. Department of Social Services, which does the IHSS program, which you're all familiar with. And then my department, these are the primary departments. We serve older adults who want to live in the community and do not want to enter an institution, and we try to help them live with dignity. That's our mission. We provide some services briefly funded through the Older American Act. These are the underlying services that are necessary for people to live in the community at first sign of trouble. So you would call us when grandma or spouse or somebody needs assistance. We have caregiver services, which I know came up earlier. We do caregiver support. That program has been pretty well funded, actually, by the feds. And it depends on a system of volunteers. It's not paid caregivers, it's informal caregivers. We're the senior center that provides lunch. We do supportive services. We do some case management. We do transportation. These are all locally determined priorities set up through our 33 area agencies on aging, AAAs that encompass the entire state. So we have a core system of services. Budget cuts have put stress. There is less money in the aging network today than there was 2 or 3 years ago. But despite that, the core Older American Act services still exist. The infrastructure is still there. It's troubled and stressed, but it's still there. And I think that's an important foundation to be aware of. Our department does also is involved in some medical side programs, and that is the adult day health care. That's the medical side. And the MSSP program, which is a waiver program that provides case management, helping people who would be otherwise in a nursing home stay in the community. So that's a basis of what our department does. One interesting thing is that it is the right thing to do to provide home and community-based services. It's the right thing to do. But we really can't tell you, is it cost effective? And that's what some of the studies are going to help us prove, that it's cost effective. And this is a really big problem. One of the reasons we can't tell you whether it's cost effective is because in my view, is the state has had a policy for years of no wrong door. And so we have this silo and that silo, as we've previously discussed. And each of the different silos has their own data system, which of course don't talk to one another. So we don't have the ability to capture data across all these systems. Exciting things are happening. There's efforts going along in the department through stimulus funding to address this, but it's a long-term effort. And we are where we are. Another issue along with this is something called the woodwork effect. And IHSS is a good example of the woodwork effect. When it started out, it was a small program, but it's a very popular program. People like it. And so when they learned about it, they came out of the woodwork to access the services. And so the program grew. And unfortunately, the lessons learned, or the scary part of this is for people in state government, particularly in the Department of Finance. Of course, this is something we all have to look at, the bottom line. And when you put a program in place that's very popular, you always worry, is it going to have the woodwork effect? And is it going to grow without you recognizing that it's going to have that consequence? On a single basis, you can always say, well, it's cheaper for someone not to be in a nursing home, $72,000. It's cheaper to have them live in the community. Single basis, that's true on an individual case. The problem with the woodwork effect is you can't say that everybody who is in IHSS or MSSP or any of our programs would necessarily go into a nursing home tomorrow. So is it cheaper or not. You know, when you have big numbers of people who then access the service, it may exceed the number who would go in a nursing home because nobody wants to go in a nursing home. So we do everything in our power, including sometimes living in very bad situations, to avoid going to a nursing home. So this is an underlying fear, I think, that causes people not to leap into entitlements for home and community-based services, and it's a reality that needs to be thought about.
Can you clarify that point, though? You're saying that I know in the materials it said that the cost was $55,000 versus $10,000. $55,000 if you're in a facility versus $10,000 if you're in home, and you're saying that we can't make the assumption that everybody that's being cared for in the home would be eligible to go to a facility, or would
either one
need to?
Both. We just had testimony. There was a hearing yesterday on the impacts in the Assembly about the budget cuts, and the testimony was from the IHSS program that they cannot tell you that how many IHSS clients are nursing home eligible. That's not the basis of how you get into that program. It is for the MSSP program, so I'm throwing a lot of lingo out here, but it's just not the criteria. And so there's no way to say that everybody on the IHSS program would go into a nursing home tomorrow. We don't have any information about that. And we know that not everybody would, but we don't know. So we know some absolutely would. We just don't know the number.
But I guess maybe that's where I'm confused. So is there a question then of whether they even need the structured care that they're being provided at home?
The IHSS?
Yes.
No, I think they have been assessed on the social side as
needing that structured care.
Yeah, safety issues or other issues that say that this is important to their living at home. Now, there's degrees. There's some people who need it more than others, and that's why they get more hours than other people.
Okay. So is the 10,000 number, is that reflective of what? The institutional cost versus the IHSS cost? The 10,000 number, what is that based on?
I don't know what that refers to. LAO numbers? Okay, came from the LAO.
I think this is what I was trying to get at earlier. I think we have real misunderstandings about what a nursing home historically has been and what we do in the community. Mm-hmm. It used to be that a nursing home was skilled nursing. Right. Medical services is why I keep trying to go there. And many of these people don't need that. So oftentimes in the past, we would put people in a nursing facility who actually didn't need that type of care. What they needed was help with dressing, help with hygiene, but we put them in a nursing home. So now we've gotten more sophisticated about this. Now we try to say, okay, they need some of that, I'm going to call it domestic care, but they don't really need an RN or LPN to watch those other kinds of functions. And I think and you correct me if I'm wrong, I think we're having problems of pulling this apart and looking at, okay, when is time to send a person over here, and then how can we provide all those domestic care services without sending the person to this kind of institution?
Well, and I guess that's where I'm confused.
And this is expensive.
This expensive is that
right.
If there are a percentage of people that are in SNFs today that realistically shouldn't be in SNFs, and is there a number? Has there been a number placed on that? A skilled nursing facility?
Well, we are in this state. We have various programs that are trying to get people out of nursing homes, and so we're looking for those folks and trying to assist them to leave the nursing home so they can live in the community.
But you're trying to get them to leave based on what Commissioner Anderson said, which is they don't need that level of care that is being provided at the SNF.
Some of them would, because you can get nursing care in the community.
We are developing new systems that can support people in the community that perhaps didn't exist, 10 years ago. We're getting better at that because that's what people want.
Well,
large numbers of people not in the nursing home need what's called queuing. They're Alzheimer's clients, and so they can many times feed themselves, but they need to be reminded to be queued to feed themselves. And so, if you don't do that, that person is not going to be healthy.
Well, I understand, and Commissioner Anderson, I guess, but aren't there specific facilities? Because I've heard the Alzheimer's mentioned a couple times. There are specific facilities for people with Alzheimer's that allow that queuing to occur.
We are developing lower level systems of care or facilities, assisted living sometimes in early stages.
Yes.
So there are choice. People have more choices today.
But okay, go ahead.
I guess my question when I read the 50,000 versus 10,000, I had a question of saving costs because you have them in a closed location. A facility can hire 5 nurses, I'm just throwing this out as an example, take care of how many people. But if I have a nurse or a caregiver that has to go around to different houses and families, isn't that more expensive than a contained service versus a mobile service? I don't know the answer to this. I'm really asking a question. Is a mobile service wind up being more expensive than a contained service?
Well, they're serving more people, so I think depending on they're at some point, at some times, it is more expensive to be in the community than in the nursing home. There is a point, but in most cases, you can live in the community on an individual basis more cheaply than the going rate of the nursing home. But it's not true in all cases.
Okay, and so my when I saw this, I asked the question of, okay, individually this makes sense, but a nursing home doesn't take care of an individual; it takes care of a group of however many. And in the community, you may have, let's say, if in the nursing home, if I have 100 people in the nursing home and I have 100 people in the community, is it cheaper because of that mobility cost versus a contained cost? And again, I don't know the answer to that. And has that been looked at like that?
I'm not an expert in these cost areas, so I probably am not the correct person to fully answer your question.
I see. I'm on the same page with you. As I read the numbers, and then you just used the number of 72,000, not 50,000.
Those are modern numbers.
So the modern number is at 72,000 to be in a facility.
And we were using those previous numbers because
it's gone up
the
40
year that they had
gone up 40% in 5 years.
Yeah.
Right. So that was when LAO measured those things across all programs.
Yeah, but again, it's gone up 40% since 2005. So the question now is if it's really 72,000 per facility, there are large communities, for instance, mobile home communities where if someone in a mobile home community needs a level of service that could be provided by a SNF, but realistically, if you could let them live at home, live in the community, can you take a whole neighborhood approach where you have whole neighborhoods of seniors, and create kind of a doc in the box type component that goes around and cares for larger groups of population. And would that be cheaper than, again, if there's 100 people that all need services, I don't want to put 100 of them in a skilled nursing facility at $72,000 each if they only need to be checked on, queued, et cetera, that's a possibility that model could work.
Yes. In fact, in closing some of the developmental centers, and again, I'm not the right one to talk about this, Terry Delgadillo has, the director there, has set up a housing component that has all the supports, and that's a very high level of support if you're in a developmental center. So probably similar to the model you're talking about. I'm not the one to tell you about it, though. She would be able to give you more information about that specific model.
Okay, But I guess let me just ask this final question. You would say that we should be concerned about the increase in cost for SNFs.
If everybody who is eligible to go in a SNF in California wanted to go in a SNF, it'd be very costly. Fortunately, people don't want to go into SNFs, and they find friends and families to help them and do everything they can to live in the community. And so it's a kind of a curtailing of it, if you will. But if we don't have the home and community-based alternative for folks, particularly folks who don't have family supports or the income levels to pay for some of these things, people have no choice.
But again, that's where we're on the cusp of. I mean, if 2011 is our danger zone, the beginning of our danger period,
right?
We better come up with something quick, like now.
That's why I'm glad you're looking at this. No pressure.
No pressure, but you know.
California has done pretty well on one measure. I said we didn't have much data, but we do look countrywide at the amount of Medicaid dollars in California's Medi-Cal spent on institutions versus home and community-based services. And in California, we are one of the better states in terms of spending less on institutions and more on home and community-based services. I would attribute that to IHSS in great degree because the expansion of that program has allowed many people to live in the community that otherwise would be faced with other choices. We know that in our MSSP program, it's a case management Medi-Cal waiver program, about 90% of the people in that program access IHSS in addition to MSSP. So that and these are people who are eligible for nursing homes, who've been deemed to be eligible for nursing homes. Interesting, CMS has just come out with a new assessment instrument. It's called Minimum Data Set 3.0, and what it requires is that when nursing home residents are assessed quarterly, that they be asked the specific question, do you want to leave? And I anticipate that many of them will say yes. And if the answer is yes, the requirement is that the state designate an entity who would help them, who they could call, who would help them leave the facility. This is a huge, in my view, opportunity for the state to designate a system entity, not just haphazardly here and there, with a relationship, but to develop a system that's going to help people exit the nursing homes. Because I do believe people are going to say yes to the question. We already have mentioned today the Aging Disability Resource Centers, ADRCs, and this is a federal grant program that actually came through the Administration on Aging. California, unfortunately, only has 6 of these. We are allowed a $200,000 grant to implement one, and so is Vermont. So you can imagine the difference in coverage there. So we have 6, and I'm sure there are some states that have a lot more coverage than California. But nevertheless, these are designed to link the ILCs, the independent living centers, and the aging network. So you've got the disability, persons with disability linked with the aging older adults. And that's the ADRC. It's a coordination of access services. And in my in the federal mind, this is the point where a lot of this work could be done to divert people from nursing homes and access home and community-based services. That's one of the intentions of the ADRCs. So we have a great opportunity with this CMS new assessment instrument to use it in a way to designate and start to build a real thoughtful system of how we're going to link the medical system with the social system so that it's seamless for the consumer.
Okay, okay. So when I go back to what you just said, that we now can ask someone if they want to leave.
In October.
In October. We can say, Marilyn, do you want to leave?
I do.
And she says she does. And you then will try and find a place. She has to tell you where she's leaving to?
Well,
no.
the question was asked. CMS, that's the medical folks.
Mm-hmm.
You know, they said we're going to put in this system, and then the people on my side, the social side, said, well, all right, who's it going to be? Thinking, well, we'd love it, you know, to be somebody, a single entry point. Who's it going to be, and is there going to be any funding to do this work? Well, CMS said, well, the AAAs, the Area Agencies on Aging, the ADRCs, you're already getting paid by the Older Americans Act to do this work. You don't need any more money. Well, I don't think that the numbers that are going to say yes. I think the numbers that are going to say yes are going to be a lot.
Sure.
And that our little core system or any other little core system in California is not big enough to really respond adequately to that.
So Maryland's going to have to stay.
Well, people are going to do the best they can, and we have ADRCs in 6 areas set up who are better equipped to do this.
Okay, so let me ask you this question. I mean, maybe and I just want to make sure I'm not driving in my mind down the wrong path here. If Maryland, because I go back to what you said, Commissioner Anderson, which is you have a population that's retiring, where a lot of them didn't have families, didn't have children. So fast forward 8 years from now, and every time you get a chance to ask Marilyn if she wants to leave, she goes, I do. She didn't have any kids, and somehow she's going to be allowed to move back into the system. So, but today we don't know where she's moving to. We just know that she says I do, and you say, okay, we'll do what we can to get you out. So, and I'm still focused on this whole thing of what you said, Commissioner Anderson, and skilled nursing facilities. Realistically, should the state and the federal government be looking at a network of independent living centers that don't have the same level of medical staff, but provide a place for Maryland to go where she has...
That would be the ADRCs, the combination of the Area Agencies on Aging and the ILCs. It's a partnership between the Aging Network and the persons with disabilities.
But it would be a facility they both operate? Would it be virtual? I don't know.
In California, it's developed as a virtual, and it's really, we're not fully developed yet. But the first steps, this is brand new, really. It's just a few years old. But the first steps have been to develop a virtual, seamless information and referral and assistance center.
Okay, and so basically, Marilyn, you're virtually living somewhere else, but you're really...
You can tell
you're
me
still there
because I have Alzheimer's.
I understand that.
I don't understand. Call on the phone.
We call, but again, I'm concerned because
it's not there yet.
It's not there. It's not. I mean, it's not there yet.
It's not.
And you're gonna have a bunch of people that say, "I want to move.
Right.
I want out."
Right.
So we don't have an answer to that question. And again, that's why I'm asking about the network. I know you're saying virtually they're going to be better connected, so we can answer more questions and provide more information. But boy, this makes me nervous.
Unfortunately, I just heard about this a few months ago, so I don't know how long the feds have been planning this. But this is kind of
this is kind of the same as the healthcare debate.
It's very sudden from
a bunch of stuff
and no resources.
But on that point, don't we have a model for that in places like Leisure World, where there is a concentration of seniors? And they stay in their own apartments.
Generally, though, they're all. I don't know that Leisure World has a case management system for the entire community. I think they're kind of on their own. Each
establish one.
Well, yeah.
And that's what we should be looking at.
Right. Another piece that
you're going. This hits on, to me, the cost issue. Is that the cost of keeping someone in their home or keeping someone in the community is a housing cost that is not being put into this equation against the institution. So if I'm going to bring somebody out of a nursing home or whatever institution I have them, I have to house them.
Correct.
And most of this housing is subsidized housing of some way or another. So it seems to me that we can't segregate housing issues out of this issue.
Because that's the yeah.
So to me, the cost now goes up here.
Well,
And I'm back to my notion about mobility versus institution. Because once I put housing into this, don't I start to have a driving of the cost that starts to look closer to the institutional cost?
Yeah, but Megan is going to touch on some very exciting programs that grants that the state has and is working on. But one of the keys to this is hospital to home transitions. Many times people first enter a nursing home after they've been in a hospital 3 days. Medicare pays for it, and then the easiest thing to do is to just move the person into a nursing home. The key would be to have that single entry point, which Dr. Hendrickson talked about, provide this options counseling, which is before you leave that hospital, you're assessed and you're given your choices. Can you live in the community? If so, what would it take versus the nursing home? And again, the question is asked at the hospital, do you want to go into their nursing home or do you want to go home? And that the services and that someone be capable of helping those people move into the community as opposed to going into the nursing home. Then we don't have the housing issue because someone hasn't lost their home at that point. After they've been in the nursing home a period of time, the rent hasn't been paid, and that's, the housing issue becomes even more severe. So if we can catch people ahead of time and prevent institutionalization that perhaps there was another way to manage that. And again, the health reform bill does have some encouraging opportunities, grants, and the Class Act, lots of things that are going to push this along. So I think the timing of what you're looking at is very, very helpful in terms of other things that are going on nationally.
Commissioner Anderson, I'm with you. This really is a concern because, if you look at what we're going through right now, with the mortgage crisis, and there are a number of people who now don't have a home, who, and you start talking about asking people if they want to leave. I would just think that we would be focused on this housing piece because, or this community piece that has a real foundation. I mean, we said, where do I sit in Maryland? And if we can take retirement communities now and build the model around the existing retirement communities and start to work with that, then you can learn a lot and prepare for, again, the onslaught that is approaching. And the housing piece is significant because you have to have some place to put someone, and maybe people would argue that you don't want to have everybody centralized in certain areas, but again, if you can put someone in a community where there's a support structure in that community because there are other people that are receiving, a level of care and oversight, and there's a support level that just comes from the other people in general who don't need the same level of care but can offer help and support. I'm not following how this is going to work, and maybe it just needs to develop. But.
You'll be encouraged to know there's something called NORC, naturally occurring retirement communities, where people in an area have said, we're going to fix this ourselves, and so they're working on building support systems, which they pay for. So this isn't for low-income folks, but they would pay a monthly fee, and they kind of get a concierge of home and community-based services.
Sure.
Yeah, Villages program. And so on the private side, this is kind of being things are happening.
But should we be encouraging maybe the private side development?
It's happening.
And much more aggressively.
There are grants out there. I think SCAN has a grant that is working on the Villages concept. There's a lot going on in this area.
I wanted to recognize the executive director. He had a question.
Ms. Dodger, looking at Area Agency on Aging as a model, and looking at this new thing that's being tested out with the 6 different places, is that robust? I mean, looking at it as kind of a chassis, is that robust enough to say add on the IHSS and the MSSP programs?
The single entry point needs to link. So right now we're all on the social side, the ADRCs, and they're not fully developed yet. It in my view, it could be, and there's money in the healthcare bill to continue the development of these. But what needs to happen is it needs to link to the medical side. So someone needs to be able to know, am I eligible for Medi-Cal? And that's done right now at the county level. So we need to think about how that's going to be seamless with the ADRCs and how we can link those things together. Because if it's too hard, something's not going to be seamless and we're going to miss the boat. So getting that all together and seamless is the trick and the challenge. And right now we know the Medi-Cal eligibility things are done elsewhere. So somehow we need to link that strongly together.
I guess I have two thoughts, which will form questions. Is the medical side always swallows up the social side, or at least historically has. So my caution is be cautious of what you seamless with. And I think it's important, but the medical funding sometimes overrides the social part. How would you look to make sure that the social components of these have integrity and can last over the medical being brought in? The next question is that your program really focuses on the elderly, but there's a whole group of people out there who are disabled, who are not elderly, who don't even have, well, the last time I looked, didn't have this kind of services like the Older American Act. They have a different set of services. How would you see your programs for the elderly and the young disabled coming together in a way that doesn't harm either one?
Well, I like to tell my other department directors that all their folks are going to be my folks at some point. and so it's all about your functional needs, and both populations need the same functional services in the community. And that's why the Aging Disability Resource Center is such a hopeful step, because it does link both populations. And the requirement is that they both work together. You can't have an ADRC without both the AAA and the ILC participating.
Could you envision or think about, or what do you think about having a one-stop shop that where if you have any of these needs, you come in and...
That's the ADRC. But that's the goal of it.
How do you think, and I know you may not be able to answer this, the young physically disabled would respond to that kind of one-stop shop programming?
I think it would depend on whether they're successful at keeping folks living in the community. It's all about results.
I wanted to ask you a question. You mentioned, I think the term used was woodworking. We'll talk about the creation of the program and growth in the program. And this is one of the things I always find interesting, because this program's obviously grown a lot, over the years. And so you create a program, and it is more successful than you planned, and it grows and it grows and it grows, and then eventually it maybe grows too big and it becomes a target, because when times get tough. So when you set the program up, you have eligibility criteria, and you have certain thoughts in mind about how many people you're going to serve, and you go way over what your expectation was. Do you ever revisit the eligibility criteria to scale the program back, or do you just let it grow like Topsy until it just keeps getting bigger and bigger?
Didn't Dr. Henderson laugh at that answer? Wasn't that when he chuckled about trying to scale things back? I think you end up in court. And in fairness, I did mention that we have rebalanced in California.
If it's a legislative fix, you don't necessarily end up in court unless you've got a federal mandate that's that's part of it.
We have rebalanced in California. We're doing pretty well on the one measure of institutional versus home and community-based services. And again, I think any person would say that certainly part of that is IHSS. What we don't know is where we would have been had we not had IHSS, or if we hadn't rebalanced, would the cost have been more expensive than the expansion of home and community-based services? That's what we don't know. There's been some testimony in Washington. There's some experts, I think at UC San Francisco, that have tried to look at this. And what they have initially concluded is that states that do this rebalancing and invest on this side have higher costs for a period of years. And then at some point where they would have been, the higher costs level off because you've kind of accommodated everybody who wanted to be in that system. But if you had done nothing, the line would have gone higher. The problem is nobody knows when that point occurs, and if California is still going in this, or if we finally turned the corner and we're leveling off. We just don't know. There's not been any data or study that captures that for us.
And just, you may not be able to answer this, but just anecdotally from your own experience and your own observations, we hear a lot about fraud and waste in IHSS. Lots of times it's prominently mentioned in political races and in other venues. What's your sense? Is fraud and waste a big problem, a little problem, an overblown problem, no problem? Give me your editorial view.
I really don't know. I talk to some people, they say yes. I talk to some people, I say no. I'm very leery of anecdotal information, and I honestly don't have an answer on that.
Does anybody?
I don't know. I mean, I think there's some testimony from various counties about their beliefs and their programs now that are funding some things. So I don't know. Maybe we'll find out. I don't know.
Well, as a fault to that, though, the perception is there, in part because of the rules that are in place that allow a person to be a part of the system and be paid for providing in-home support services. And I think there was just some major reforms as part of the budget last year.
Yeah, and it's going to take a while, I think, to see the results of those. And part of it is this money that Ms. Doucher talked about.
And there is strong testimony from various counties that they believe that this is a problem. And so the legislature had put some actions in place.
Did the reforms go, in your opinion, the reforms that were implemented, that we're waiting to see the results, did they go? I mean, well, I guess it's kind of hard to figure out whether they went far enough, but you think they covered the areas that were of concern?
I don't oversee IHSS, so I'm very uncomfortable talking about that program. I know as much as you read in the newspapers really about it.
Okay.
So, but I think
I'm sure someone that has testified probably has looked at the reforms.
And I think there was agreement to put these reforms into place.
But it was a struggle. Well, and that we probably should get more clarity, because I heard it was a struggle, and there were still things that they did not put in place that again help on the perception side of the fraud and abuse. So.
I think we'll get the data systems. I mean, that's one of the things they're talking about, and you'll get some numbers on it.
I think one of the problems that people have with IHSS is that often we pay family members to take care of family members.
Sure.
And some people don't view that as being legitimate.
Mm-hmm.
And so anytime you have a person in there who's a family member taking care of a family member and we're paying them, you have people looking at it with probably problematic eyes. But my theory has always been a lot of family members give a lot of free service as well as, and probably charge a lot less than they would get if they were not family members doing it.
And I don't know the answer. Are they? I assume that before you can be paid, the parent or family member that you're caring for has been assessed by the county as needing that care.
What strikes me, and we'll be talking about this later, is that I think I think over the years, what we're seeing, and I'm going to call this, it's not demeaning, but this used to be women's work. Now that women are not in the home, this becomes the larger society's problem, and we haven't figured out how to deal with this. Mm-hmm. First was child care, now it's our elderlies, all these things women used to do that are now shifted to the broader community. And we haven't come to grips with how do we do that? How do we take care of these people? And I think it's going to be very difficult long term to continue to have a workforce to support this, because this is not the kind of service we want to pay for, especially at the level we're going to have to pay for it. I mean, I just think we're on a collision course that we're not really prepared for. The training and development of the people and an ability to pay people the kind of wages that's going to keep people in this service. I think we're in for real problems.
But it's the same crisis we have on the nursing side in general. You know, the nursing crisis is approaching quickly, and this will exacerbate the whole situation if people, you know, I think in the budget proposal, which I'm not saying that, you know, that it isn't necessary, but the governor's proposed reducing the payment for services from $12 an hour to $8 an hour, and so Commissioner Anderson, you're right. Somebody might say, well, look, it's not worth it for me now. I'm getting out of the bed. I can go find something else to do.
Right.
So.
Yeah, but at the same token, I sit on the board of some hospitals, and the hospitals are just importing workers from all over the world
Sure.
to fill those jobs.
You're right.
I mean, let's just be realistic about it.
Yeah.
You know, nurses at the hospital that I'm involved in, I mean, I would think it's 60 to 70% overseas type of help.
Well, I'm not. Yeah, I agree with you. That is true. I think that this points to, again, as you're talking about how you address the nursing crisis, you're at some point have to aggressively address how you're going to keep pace and address the in-home supportive services care crisis, because, you know, again, the system is about to be overwhelmed. The hospitals aren't responsible for it. Somebody has to be responsible for it.
The other thing that we didn't ask the question of, as the baby boomers age out, how does their numbers in the aging population, how is that going to affect the young physically disabled?
Well, the aging numbers are going to increase demographically. But on the other hand, all people are living longer, and so more of this population.
You're going to wait till they get
Yeah.
to the aging.
Yeah.
But what happens, I guess my concern is that watching the baby boomers through the years is that they tend to override every kind of service there is. So I would have real concern, I have real concern about what happens to the physically disabled who are not aging as the aging population ages.
I think that's why it's really important to talk about functional issues, because it'll capture everybody. There's no reason in terms of what people need to separate by age if the functional limitations are the same. Yeah. Okay.
I don't think we have any other questions, so appreciate your testimony. Informative and interesting, and
Thank you.
and I think we have ready to call our final witness.
Yes, we are, and our final witness can address many of these questions. It's efforts by the California Health and Human Services Agency. We have Megan Juring. Hello. Was appointed Assistant Secretary for the California Health and Human Services Agency by Governor Schwarzenegger in 2008. Ms. Juring oversees interdepartmental issues related to long-term care and supports departments of aging and developmental services, as well as the Olmsted Advisory Committee. Good morning.
Welcome. Thank you for coming.
Good morning. Thank you, Mr. Chairman and commissioners, for inviting me to be present and discuss with you some of the activities that the Health and Human Services Agency is engaged with in the prioritization of long-term care. Right now, and even in this morning's discussion, I know that budget actions, budget reductions, proposals, and implementation of budget reductions are foremost in our minds. These proposals have been very difficult to put forward, and they have real consequences in people's lives. So I don't want to minimize that as I discuss some of the good things that the state has achieved in implementing Olmsted principles in the past few years. Part of my job today is to inform you about the policies and practices that are consistent with the Olmsted decision, And I did want to highlight something that Director Dauscher had said, is that we have made progress in expanding home and community-based services to afford individuals choice in where they receive care as they need it. California is one of few states to have achieved a level of investment that's stronger in home and community-based services for long-term care through Medicaid than on the institutional side. We, according to a 2008 study, invest 52% of our Medicaid funding on the home and community-based side, 47.9% on institutional care. Only 3 other states have that kind of a balance, and that's Washington, and spend actually a greater investment of their Medicaid funding in the community, and those states are Washington, Oregon, and New Mexico. The fiscal scorecard are based primarily on the Medicaid expenditures in the waiver programs, as Dr. Hendrickson reported. So they don't capture all of the investments, some on the social side. They don't capture many of the state's Medicaid state plan services. They don't capture investments in the managed care plans or services provided through the Lanterman Act entitlements. Programs also that are funded entirely by general fund aren't captured in those equations either. So if some of those were tallied, we would have a stronger investment on the community side, even than the 52% measure that was captured by the Centers for Medicare and Medicaid Services. But it's still a balance, a way of measuring how states are progressing in providing those options. I referenced in my written testimony that there are several components that are necessary, and a capacity of our programs is just one. Another important element is how people are connected to those programs and how the programs themselves coordinate amongst each other. In addition, there's the question of data that's been brought up already today, and financing. You know, those are main elements, as well as planning. But on the capacity growth side, just to highlight some of the figures, the growth in in-home supportive services has actually exceeded 105% in the years between 98-99 and 2008 and 2009, serving close to 430,000 in 2009, over 208,000 in the previous decade. Efforts of the Schwarzenegger administration secured federal match in years past that did help California's ability to fund this increasing demand. Also, we've referenced the assisted living opportunities. This is a new waiver that was established in 2006 and was just renewed in 2009. This waiver opportunity separates out that housing cost from the service cost. So the waiver pays only for the service cost for individuals who are living in assisted living, and individuals pay for the housing cost themselves. In addition, our nursing facility waivers broadly, our core nursing facility waivers that support home and community-based services for folks who are nursing facility eligible, have increased from 2,095 to 3,025 between the years 2005 and 2009. So, yes, please do.
Who's eligible for this waiver?
The assisted living?
Mm-hmm. What's the income eligibility?
Well, it's a Medi-Cal eligibility, and I can get back to that question if maybe I'll take it now.
Well, the reason why I'm asking that question is that you said you separated housing out, but if you're a certain income level, it's possible that in this waiver, housing isn't being paid for on the public side, but over here on the housing side is being supplemented. I mean, they're not in the same program.
So the assisted living waiver has 2 models. Mm-hmm. One is having providers of RCFEs, residential care facilities for the elderly, participate. And another model is to support people in public housing. Mm-hmm. So 2 options that allow for the care services to be brought in and paid for under Medi-Cal. So the degree to which individuals are paying for the housing side through their Social Security, supplemental security income, or other resources, that would be coming from that stream.
Okay, thank you.
Maybe I will interrupt for a second to respond to the question of Medi-Cal eligibility.
Okay.
California actually has 232 paths to become eligible for Medi-Cal.
How many?
232. These include eligibility for the mandatory coverage and optional coverage groups. The income threshold depends on some characteristics of what group an individual falls into, but for the core age, blind, and disabled group, we're close to 127% of the federal poverty level. There's also a category called medically needy share of cost. So for an individual whose income exceeds the threshold for that income amount.
127?
Yes, if they're in that particular group. And remember, 232 paths. They may be eligible for medically needy with a share of cost. So in that model, their income is established through calculation, and they're expected to contribute out of their own pocket. That's the share of cost until they hit a particular threshold that's individually calculated, and then Medi-Cal kicks in for payments above and beyond that on a monthly basis.
Okay.
There'll be a quiz after the meeting.
You lost me right after the 127%. Why are there 232 paths? First of all, I just look at whenever you see something that big and with that many paths, there has to be some inefficiencies in that structure that are costing us money, and which could be used to improve the system. But why are there that many paths?
I believe paths grow over time, both in taking advantage of opportunities for expansion over time, as well as some paths are created as a result of lawsuits. And so that's the degree of response that I'm able to provide. I think it's a worthy question.
I remember when I had to help my mother with the new Medicare B medical component, and I couldn't figure that thing out to save my life. And I'm looking at again, going back to what we're faced with, the number of people entering the system. We've talked about in this economic crisis that you have people for the first time who've never had to be a part of the system of getting support, and they get into it, and they try and figure it out and decipher it, and they leave confused and angry because it's one big maze. This is a great example. I'm not blaming you or the administration or anybody. I just don't know why. Is there an effort to review the number of paths and maybe say, you know what, we can consolidate, we can reduce, we can make this easier. We may find some efficiencies. Is that an effort that is being considered?
It is a question that was raised at the Olmstead Advisory Committee in terms of the discussion around the 1115 waiver. Dr. Hendrickson kind of talked again, if you have lots of waivers, it increases kind of your fragmentation. So members do kind of call on how do you simplify something like this? And it's certainly something that would be analyzed in the context of the new federal legislation as well.
His response was off with your head. I mean, that is what the Queen Heart said.
But would you? I mean, okay. So, but you would probably agree that there is probably some this doesn't set up well for the most efficient operation. Would you agree with that, or?
I agree that it's challenging in its complexity, both for eligibility workers locally and as a program to manage.
I mean, they have to probably give you some cliff notes when you got your job. They go, hey, read these first and then read them again. I mean, I just don't.
Counties do have eligibility systems created in computer software that individuals' information is input from their application.
So that we don't ever have to really figure it out. Really just let the computer do it.
And as programs change, those computer systems need to be updated to make sure that individuals' options are appropriately analyzed in those settings. Humans also need to analyze that, and Medicaid eligibility workers have a really tough job.
So Mrs. Dowsher, when she said they're going to try and create this model of kind of a one-stop, when Marilyn gets allowed to leave, she will have this one-stop spot that she can figure out all of this, which of the 232 paths she may be eligible for?
So likely she is eligible through one path as she's in an institutional setting, and part of what would need to change is how does that eligibility path change when she's in the community, and it is an important and very vital step to consider for individuals as they're transitioning from a residential setting, skilled nursing setting, and into the community.
But is there any chance she's going to feel? I mean, if she's standing there at the kiosk trying to figure this out, I mean, I'm asking this seriously. I don't know how we make this work.
So I would like to refer to the California Community Transitions Demonstration, which is managed at the Department of Healthcare Services. It's a federal award which allows the state to have an increased federal match for individuals who are successfully transitioned from long-stay nursing facilities, such as the commissioner. And it also allows for certain transition services to be paid on a by-service basis for organizations, community-based organizations, to work with the commissioner while she's in the skilled setting to set up what's needed for her to be safe in the community upon a transition.
Okay, so there's a nonprofit that can come in. She said she wants to leave. We're going to let her leave. The nonprofit's going to stand there with her at the kiosk to figure out how she transitions and what she's eligible for.
The transition organizations range from, there are 13 lead organizations currently across the state serving approximately 35 counties. In some cases, it's a home health agency is taking the lead, and they're called lead organizations because it's their responsibility to be connected with what are those services in the community that the commissioner is going to need when she gets back, and that Medi-Cal eligibility piece is one. So the organizations do a lot of work both in providing transition preparation while with the individual in the skilled nursing facility, but also making the calls and being out in the community to ensure that set of services is actually in place. So it's that piece is not virtual; it's real and tangible. And the commissioner would not be discharged by a skilled nursing facility until they are assured that it's a safe transition. Those regulations don't change.
So you're almost home, Marilyn. Well,
I don't think so.
I didn't say that you were there. I said you're almost there.
So I also want to indicate that the question about a resident's interest in returning to the community is a current requirement as well. What's different about what we're planning for implementing October 1 is that currently discharge planners or staff within the nursing facility might determine that, you know what, it's just going to be a confusing question. It's not in her best interest for me to raise this. And in beginning October 1, everybody needs to be asked the question and walked through the set. There's no staff discretion in that. And that next step, so you say, yes, let's get you connected so that someone can come in and do those assessments and work with you.
And they pick from that provider list? I mean, you said there's 13...
That's and as Director Dauscher mentioned, the Aging and Disability Resource Connections also offer a lot of that assistance in connecting community-based services. We had a panel at our Olmsted Advisory Committee meeting together with association representatives from nursing facilities, Department of Public Health, Department of Aging, and Department of Healthcare Services to kind of raise this issue, how much planning there's to be done between now and October 1.
Are the counties involved in this discussion?
I have not convened a group that includes the counties at this point in time.
But go ahead.
That was getting ready to be my question. Given the county's budgets, right now most of them have really been slashing their social services side and their nonprofit organizations. In October, this is not a city issue. This is usually a county issue. Who's going to be ready to surface this? And how are the counties going to do this? given the counties I've looked at have been really dropping, have been reducing the money they're providing to nonprofits, have been laying off staff in these areas. Where is this service going to occur?
Well, first of all, in the planning for this, it makes it sound like everybody in a nursing facility now is going to be racing into the community. And the departments and the nursing facility associations are going back to kind of look at their data. Many of the residents in nursing facilities currently are short stay rehab, and this is a process that takes place for them currently. There wouldn't be a huge change with the October 1 implementation for that group of residents.
Hold on. So you believe that there's going to be a small number of people who are going to say yes, who wouldn't normally have been coming out anyway? Because
we don't know that number yet. The associations will be looking at what their populations are. Department of Public Health is going to look to see, is there a way to quantify to help us better prepare and plan? And then again, because that data could hopefully be local, that's a good conversation to say now, what are the resources available in this community?
My suggestion is whatever you think it will be, add to it. Simply because this is an experience you haven't had before, and if you base it on your past experience, that's not going to be accurate. So I would add more than I would be normally anticipating. That's just my thought to share with you.
Commissioner Brewer had a question.
It sounds to me like this is a risky plan. You said that you just said that well, most of the people would be people who are short-term inhabitants of a nursing care. So they have a higher probability of success of going back out into the community because they've only been in the nursing care home while they had a hip replacement or something. That's a given. If they can be rehabbed and they've only been there a short time, why do you need a specific program to service them? And then if you're looking to expand it to people who have been there for a longer period of time, it's the law of diminishing returns. It's not like you're dealing with teenagers who are going to get better and mature. You're dealing with seniors who it's a declining thing. So I'm lost here as to the effect of this program.
Your point is taken. The changes that are coming October 1 are changes in federal requirements for the minimum data set, which applies across all nursing facility residents without concern of who's the payer of the nursing facility individual stay. So it's a rule change. Members of our state teams will be going to Baltimore in April to learn more from Centers for Medicare and Medicaid Services about the expectations for this. And so there is that's occurring. The California Community Transitions demonstration serves folks who are Medicaid eligible, who have stayed in nursing facilities 6 months or longer, who would have challenge in getting connected to those community-based services that they would need in order to transition safely. It, again, is dependent upon the individual's wishes and the ability of those services and supports and housing to be in the community for them to make that transition. It's an individual assessment, and it's not a wholesale plan.
You had 200 people that that made the transition since 2008.
Approximately 200 have been transitioned, not all of them through the demonstration, but as part of the organizations who have been in the nursing facilities. So they may not have qualified for the demonstration, but they still received assistance to transition home.
How does that demonstration, what kind of information?
What kind of information is the demonstration giving you in terms of your planning for this new requirement?
The experiences of these 13 lead organizations are telling and important for us to be learning from them. Housing is a major barrier. that Medi-Cal connection piece for the community-based services is important.
I'm still going back to my housing as the issue. How much relationship coordination are you having with, what is the name of that housing agency?
Housing and Community Development?
Yes, that one. How much are the two of you working? And that's under a different agency, right?
Yes, they're.
How much are the two of you working together around this, or is this?
Housing and Community Development does send representation to our Olmsted Advisory Committee members, so they are to our meetings, so they are engaged with health and welfare, with our agency in this discussion. And in the opportunities through the California Community Transitions Demonstration, the federal government has now allowed that for certain activities and staffing needs to affect transitions could be paid 100%. The State Department of Healthcare Services is talking with Housing and Community Development to see, is there a housing liaison function that we might apply to receive funding to pay to strengthen that link. So it's a critical issue. We're in that discussion now.
One more question. How much cost shifting does this do, and from what program to what program? When you have this call to leave the nursing home, what kind of, who's saving money here, and then who's gaining the financial responsibilities?
With just under 200 individuals transitioned, I don't know that there's enough data to do a full evaluation of that right now. But our home and community-based services study, which has been referenced, I could mention that. Okay. That question of the cost effectiveness and the totality of supports that someone is receiving through the home and community-based service network and system is important to study. And the comprehensive study of home and community-based services is looking across programs based on an individual's experience to capture the services, and also utilization, whether it's Medicare expenses or Medicaid. And it will be a 4-year study between on individuals' experiences from 2005 through 2008, because that's where the year that we'd be able to capture the most information.
I have a concern, and as you get information, I would hope you share it with us, that this is the federal government shifting more financial responsibility to the state.
Thank you. I'll make the notes.
Right. That's what my concern is that they're offloading to the states.
In the California Community Transitions Demonstration, I will note that the individuals who are Medicaid eligible and long stay, that would be a Medicaid cost only, and Medicare would not have been a payer at that point in time. So it's really focused on that state and federal Medicaid program costs.
Well, you said that federal funds provide greater match for these individuals for 12 months post-transition.
Yes.
So 1 year. For 1 year after the transition occurs, you'll get a bigger support package from the feds.
They'll share a greater percentage of the expenses of the services. Yes.
After that,
it's back to our standard federal match, which currently is 50%.
See, before it was, if I'm understanding right, it was the feds paid the total cost. So as we shift them out, we're moving more and more to state.
yeah, the state's picking up
right.
a 50% cost.
No, we have the federal match within the nursing facility as well.
How much?
It was in the. It's in the
50%.
Yeah, that's right. That's true.
50%.
That's true. It was 50%.
Yes.
Executive Director had a question.
Ms. During, when you're looking out at the options that you have and planning for this rule change and the general theme of more Olmsted-driven moving folks back into the communities, do you where are the areas that you feel that there could be? I mean, do you feel that you have the range of options that would be ideal for this, or is it where they all move to an IHSS type situation? Where do you see that there's gaps? Or
One of the elements that we focused on through our California Community Choices Project, which is a grant that's administered by the Health and Human Services Agency, is that people have access to information in a timely way. Frequently, we're searching and grappling for that information when we're in a crisis, and it's not easy to find. How many phone calls can you make? So we are piloting a web portal that provides information on licensed care services statewide, institutional and home and community-based. And in 2 counties, Orange and Riverside, they're testing having that data set also populated with all the local information. Some of those local resource networks are established through 211 systems. That might be something that we can pull and migrate their data into this statewide web portal, so that no matter if you're in Alameda but looking for services for your mother in San Diego, you have a go-to place for reliable information about services and supports. So that is one area that we've identified that would be effective and make a big difference in people's lives.
I'm always concerned about rural areas. Are you doing a model like in a northern county or one on the other, like over in Susanville area, someplace that's not so service concentrated?
Yes, so in the California Community Transitions, they are serving in 35 distinct counties. So that's a good question to poll and ask them amongst themselves, what are the challenges that may be different in rural communities than urban. In addition, the Aging and Disability Resource Connections, the director mentioned there are 6 across the state. They are in San Diego, Riverside, Orange. There's one that serves multiple counties out of the Chico area, so we're getting more into the rural area there. San Francisco. I was not counting while I was speaking. And Humboldt, thank you. So that reaches as well the far north.
North Coast.
35 counties aren't.
We have 58. We have 58. That's why I read that too. It says 34 in the materials, and I was wondering about the gap between the. And your question, Commissioner Anderson, is a good one, which is of that 34, 35, most of them probably are the urban counties.
Yeah, I don't have that spread for you, but I know Department of Healthcare Services is creating a map so that we can identify where our gaps are, so that we can do additional recruitment for programs to raise their hand and say, yes, I want to be a Medi-Cal provider and work with you on this really tough and meaningful work. So we are continuing to seek providers who are qualified to be able to do this work in the remaining counties.
The east side of the state on the other side of the mountains really concerns me, which we tend to think north a lot, but I don't think we tend to think on the other side of the mountains. I'm going to say going to 365, the highway going down.
395.
395. We don't tend to think about that part of the state.
Should we cede it to Nevada?
It's minerals in them there locations.
Might lose Mammoth.
Right.
No.
We can. I'll provide this information back to the.
Ms. Juring, we've been asking a lot of questions, and I wanted to make sure you got a chance to, if there was any parts of your testimony that you didn't get a chance to talk to us about that you wanted to, that you got an opportunity to finish that.
I would like to add that in addition to, I think, the projects that have been mentioned earlier by others as well in their testimony, that Health and Human Service Agency had partnered with the Alzheimer's Association to solicit funds from private philanthropic partners to support developing a state Alzheimer's disease plan. The Alzheimer's Disease and Related Disorders Advisory Committee is part of our agency and is tasked with advising the Secretary as well as the legislature on issues relating to Alzheimer's and related disorders. And it had been 20 plus years since a planning effort had occurred to look at issues for this population, and we believe that this effort is extremely important as well for the broader Olmstead implications, as has been noted. The services and supports that this population and families need apply more broadly as well. So I'm pleased that more than $250,000 was secured with leadership from the SCAN Foundation stepping forward first, and then four other private philanthropics have funded this effort, and that's housed through the Alzheimer's Association. We're pleased to be part of that effort.
I do have one other question.
When I think of long-term care, one of the groups I actually think about here that we haven't talked about all day is those with chronically mentally ill. Because that is a long-term care issue.
That the counties are struggling with now.
But we've talked about the physically disabled, we've talked about the developmentally disabled, and we talked about the seniors. We haven't talked about them. I haven't heard any mention of that population as part of being in the long-term care population, or any thinking about that. And so my question to you is, what kind of thinking is going on? Are they looking at including them in or excluding them? What's the long-term thought about that?
Absolutely. Folks with mental health needs are, whether it's a sole diagnosis or a dual diagnosis, are impacted in long-term care service and support issues. The Department of Mental Health Director, Steve Mayberg, does sit with other directors as part of our Olmstead Advisory Committee discussions regularly, and we have representation from the Mental Health Alliance on that committee as well. In the written testimony, I did mention that the Mental Health Service Act funds had been targeted to support counties' efforts in supported living environments, and I'd be happy to provide the Commission an update on that written in the future to let you know how those housing projects are going in the counties.
Did you finish?
Yes.
Okay. A couple of quick things I wanted to ask you. I think it was in 1996 this commission issued a report, talked about a number of reorganization possibilities within the various components that we're touching on today. And I think that was generally well received, and others have endorsed the ideas. We heard from Dr. Hendrickson this morning. He basically said, forget it, it's a waste of your time because it's not going to happen. Do you agree that reorganization or streamlining of the organizations under the HHS umbrella, that consolidation organization, are those a waste of time?
I don't believe it's
because it's kind of what we usually do. So,
no, I would not state that it would be a waste of time. I would challenge that the goal of such a reorganization would ultimately be to impact and make efficiencies in the service delivery at the local level. And so the degree to which changing state structures would impact and improve systems locally, it could definitely be worthwhile. It is something that was.
Do you guys talk about it sometimes, or?
It was raised in the California Performance Review, and is referred to within the administration over the course of time. It isn't something that we feel is financially or fiscally or resource-wise a priority to do right now. Many of the projects that I had described are ways that we are intending to improve that local service delivery system without a state restructure. Having the cross-department team come together to plan for this October 1 implementation of a change in the nursing facility transitions is one example. Having a web portal that includes information about services and supports that span licensing from public health, social services, Medi-Cal, that's another way that we are trying to improve the efficiencies locally and make information more available no matter what type of service through what department somebody is looking for. So those are the efforts that we've been prioritizing currently.
The other kind of subject I want to explore with you a little bit is it's certainly no secret that the programs that we're talking about today and the programs that you administer are the target of some of the biggest budget cuts that we've seen any programs in a long time. And I was wondering if the department has a strategy or a contingency plan for how to respond or how to deal with those particular proposals. And have you developed alternatives that you'll be able to present to the legislature that identify different threshold levels of service that you can provide at different cut levels, and sort of what your general planning in that regard is?
Well, the administration remains very committed to seeking the federal support for those monies owed and for a fair share of federal participation in the programs that we administer in partnership with them. And that continues to be a very strong strategy. Certainly the budget that was put forward in January is the beginning of a dialogue together with the legislative members to find solutions and alternatives so that we can live with the resources and expend within the resources that are currently available to the state. A part of that as well is to work with the federal government to be provided and afforded the flexibility to manage our programs with the resources that we have. And we've been constrained in that ability currently.
So somewhere in the dark recesses of your office, there are contingency plans then, or?
We look forward to working with the legislature in identifying alternatives.
Okay. Any other questions? Thank you very much for your testimony. Appreciate you coming.
You have a tough job.
Yeah, thank you.
Thank you.
Okay, I have 5 requests from the public to speak. I have 6 requests from the public to speak. I would ask you, the public, to be succinct and brief. Limit your comments to the things you think that you need to have us hear. And I will call first Deborah Doctor up to the stand, please. Welcome. Thank you for attending our hearing today.
Thank you for having it. This is a little bit deja vu all over again for me, since I was one of the informants for the 1996 study and the 2004 follow-up. And I've been working on these issues since 1977, when I was very young. I work for Disability Rights California. I work mostly on long-term care and benefits issues. I'm a member of the Olmstead Advisory Committee and the Community Choices Advisory Committee, and I have lots of things that I would like to say, and I'm hoping there will be an opportunity for you to meet with advocates, people with disabilities and their advocates, all kinds of disabilities, to be asked some of these same questions.
Let me say, part of our processes are, we have our public hearings and they're a little more formal, but we have advisory committee meetings as well, and we will be doing that in this particular subject matter, and we will convene meetings that are less formal, where good interchange of ideas get to take place, and we get to hear from a lot more people than we get to hear from today.
That'd be great. I'm going to just try to cover a couple of areas. I also was the first director of the Public Authority for IHSS in Alameda County, and I'm pretty familiar with IHSS, so I actually could give you some information that you asked questions about before. But I wanted to talk a little bit about a couple of issues. One of them is the issue of diversion and transition from nursing homes, which is not just a good idea, it's the law. The Americans with Disabilities Act, which is a civil rights act and was the foundation for the Olmstead decision, guarantees people with disabilities, including seniors and children with disabilities, the right to receive services in the most integrated setting. And the Olmstead decision came on behalf of 2 women with developmental and psychiatric disabilities who were kept way beyond their need to be there in state institutions. And they sued because it was taking years and years and years for them to get out. And they won. And that decision is unfortunately named after the losing party, who's the state commissioner of social services. But those 2 women got out and had good lives. One of them was here last year on the 10th anniversary, the surviving plaintiff in Olmstead. So that I emphasize that there is a legal responsibility by the state of California to conform with the Olmstead decision and with the ADA. We don't have an Olmstead plan that meets the qualifications that were laid out by the federal government. We don't have a plan that says this is how we're going to move people out of state developmental centers or IMDs or nursing homes or anything else. We don't have goals. We don't have accountability. We don't have any of those things. I'd like to just touch on this question of who can get out of a nursing home and how many people want to. When I was a case manager back in 1980, this is not new stuff. I help people stay at home or get out of nursing homes. I suggest very strongly that if you have another hearing of any sort, that you invite people from San Francisco who are running a program getting people out of Laguna Honda Hospital. Some of those folks have been there 20 and 25 years, and that facility is getting paid about $400 a day because of its classification. And some of those people who are getting out need only IHSS. We have several studies which have documented that probably 20% of people in nursing homes in California and in other places, when they're informed about what services might be available, say they want to get out. And there is no reason to think that they can't get out. Our presumptions about who can live in the community and who can't have changed over time, and you see people in the disability community who 30 years ago would either not be still living or would be institutionalized. So my hope, and hope that it would happen during my lifetime, is that someday we'll look back upon the nursing home population and the inevitability of putting people in nursing homes the same way we look now at the developmental centers. Now, the default setting isn't going into a developmental center for people with developmental disabilities. The default setting is living in the community. And there are people living in the community with extraordinarily high needs, medical, social support, and they are doing just great. And I believe that that is absolutely a possibility and has happened for people in nursing homes, regardless of their age or their medical needs. There's almost nothing delivered in a nursing home that can't be delivered in the community. It's somewhat ironic that we hear the state government kind of patting itself on the back for the progress it's made in balancing long-term care between community institutions when the very programs that are the heart of that balancing are being, as was said, threatened with extinction. The governor has proposed to eliminate the IHSS program entirely. And then you'd find out how much your costs would go up in nursing homes. I hope that is not what we're facing. I know people who literally would rather die than go to nursing homes. And as far as cost increases, the amount that is paid to nursing homes in California has gone up about 32% over 5 years with a drop in caseload. So when you talk about programs being growth or out of control, the IHSS program has grown because the population has grown and the caseload has grown. The nursing home side has grown because they're getting paid more with no growth in caseload at all. And what Dr. Hendrickson referred to in the LDOA is an example of how money can be moved. It's not just a question of needing more money all the time. It's also looking at how we're using our money. And that is, there is no other Medicaid vendor and no other nursing home system in the country that pays nursing homes a bonus regardless of the quality of their care, and they can do whatever they want with it. It's not accountable to the state at all. They get the money, they can spend it however, literally, they wish. And if you think that that's, an efficient way to oversee long-term care spending or any other kind of government spending, I guess I would have a disagreement with you, and that's why my organization opposed that right from the get-go. So I know there are other people who want to speak. Maybe I'll stay up here in case there are any questions, and I have lots more to say and would hope to have a conversation with you at some point about work that is being done and can be done, diverting people and getting people out of nursing homes, and also expanding the conversation about who we mean and what services we're talking about when we talk about long-term care, and also when we talk about case management, because I think one of the things that was happening here today is we're using the same words and we're meaning very different things when we say them. So that's an issue my organization is very interested in too. Thank you.
Thank you very much. We'll look forward to continuing to work with you.
Mr. Chairman, I have a question for Mrs. Jring. On the issue of people getting out of the facilities, does everybody that's in a facility get assessed, or are they assigned a functional index score?
So at entrance?
Yeah, is everybody at entrance assigned a functional index score?
Not in the way that the term of art is used for the in-home supportive services program, but they do have assessments done quarterly.
They do what?
Nursing facilities are required to conduct quarterly assessments for for individuals on a whole range. That's the
Is that equivalent to the functional index score? What they do?
It would be of interest to see what are the different assessments, not just across the nursing facility assessments, but how the in-home supportive services assessment is completed, multi-purpose senior service program assessments. You know, each program really has a different set of questions that they may be looking at to identify what types of services to provide.
Okay, so based on your answer to that, wouldn't it make sense that everybody be on the same page as it relates to the functional index score? And the only reason I ask that is that the budget proposal is that if you are a functional index score of 4 or less, IHSS services go away. So so I don't know if we're assessing everybody that's a 4 or less, and we find there are a bunch of people that are in facilities that are a 4 or less, then they technically shouldn't be in those facilities and should be in an in-home support services environment. Is that a fair statement?
I would not have characterized it that way, but one of the recommendations of the long-term care finance study, which we commissioned as part of the California Community Choices Project, is to look at common assessments so that those sorts of analyses can be done. And I believe that I would defer to Dr. Hendrickson. I believe that's the system that the state of Washington has put in place. So no matter where or what service you're receiving, what type of long-term care service you're receiving, the level of that care is based on a common assessment.
Okay. So that's where we're moving to, hopefully.
That's one of the recommendations that is being considered, yes.
Thank you, Ms. Doctor, for your testimony. We'll be in touch. The next request I have to speak is from Nina Weiler Harwell. Hope I said that right. Ms. Harwell, welcome. Thank you for attending our hearing today.
And thank you for pronouncing my name correctly.
It was a good guess.
I'm Nina Weiler Harwell. I'm an Associate State Director with AARP. I work on various health and long-term care issues. I'm also doing a lot of work on the health care reform effort this year. Anyway, we want to thank the Little Hoover Commission for addressing this very timely topic, given that healthcare reform, which, by the way, just the reconciliation measure just passed out of the Senate today, given that healthcare reform contains various provisions that will better incentivize the use of home and community-based services versus nursing homes. One thing we keep noting is we keep returning to this topic over and over. And we're really hoping that at some point we can really put together some recommendations, a plan, and move forward. What we do suggest that you do is we're really pleased to see that the long-term care financing study was discussed here today. We think that it provides so many useful suggestions on how to leverage existing resources. We really encourage you to continue to dig down into the report, look at a lot of its suggestions about AB 1629 and the LDOA. Like Disability Rights California, AARP also opposed AB 1629 from the get-go. There's a lot of problems with that report. It does not incentivize the right things. In addition, also look at the suggestions and the comments in the financing report about the continuing institutional bias of our long-term care system. And once again, as I just said, we want to make better use of what we have now to incentivize HCBS. Other states have done this. California does not have to reinvent the wheel. So we do look forward to working with you. You mentioned some advisory committee meetings, and I hope to meet you again.
Thank you for your testimony. Appreciate it.
Can we get, Stuart, everybody keeps mentioning the health care bill. If we have another hearing, I would love for somebody who's an expert on this long-term component of the National Health Care Bill could come and address.
All new to us,
yeah. Yeah, I mean, I think that's important in this conversation because everybody keeps referring to it, and somebody in D.C. must understand all the intricacies and what it means. So, somebody. I didn't say who.
My next request is from Jackie McGrath. Ms. McGrath, if you could come forward. Welcome. Thank you for attending our hearing today.
Thank you for having me, and thank you for being here. Mr. Chair and fellow commissioners, I'm Jackie McGrath. I'm the State Policy Director for the Alzheimer's Association. I'm also a member of the Olmstead Committee. I'm also currently serving on an advisory group to the administration that is putting together an expanded Medicaid waiver proposal to the federal government that would be specifically looking at expanding folks, seniors, persons with disabilities coming into organized delivery systems. And one of the challenges we are trying to keep before that group, one of the stated goals of the legislature in the bill that they passed last year, as well as in the administration's concept paper about that waiver, is to promote home and community-based services. However, I can tell you on behalf of many of my colleagues sitting out there, it's a real uphill battle to actually translate that beyond the words on the paper to some real action. But that really wasn't specifically what I wanted to address. And I really am glad to hear you say that there will be a process. I have to say, this is my first venue with the Little Hoover Commission. I'm not familiar with your processes, so I'm glad to know you're going to have a more informal consultative process, and I hope I might be part of that. I would just like to put a couple of things in context and maybe just respond to a few points that were made by some of the folks who spoke. 20 years ago, when someone received a diagnosis of Alzheimer's, it was really not an issue of whether you went into a nursing home. It was when you went into a nursing home. And what we've seen through the 80s and 90s was the growth of adult day health care, in-home supportive services, and some measure of caregiver support services, so that today only 6% of people who live with Alzheimer's are living in a nursing home. But there's no question that those numbers can quickly go in reverse. These folks are still at highest risk of going into a nursing home. So when we start talking about beginning to dismantle the infrastructure through the budget process, we really are precipitating moving these folks back into not having a choice if the capacity is not there in the community. So I would differ with Ms. Dalsher's assessment. She said that the infrastructure is certainly stressed, but that it's still there. It's certainly it is there in name. I would suggest in some cases much more in name than in substance. One of the programs that Ms. Steenhausen mentioned a couple of times, the Alzheimer's Daycare Resource Centers. This was a model that was created 20 years ago It was a real vision that people, it was really ahead of its time. It was, the whole premise was that people in middle and late stage of Alzheimer's can be maintained in the community if you have a program with adequate staffing, with the staffing trained to manage the very challenging behaviors that occur through the course of Alzheimer's. That model flourished to the point there were more than 60 centers throughout the state. And regrettably, last year, all of the state funding for those centers were removed. Now, while there has been some effort to hold on to some thread of the program, I would suggest to you that the state law has 13 mandates on what those centers are to be doing, and those mandates are certainly not being done. Just another example of how the infrastructure has deteriorated. There's been a moratorium on adult day health care centers, new licenses for the last 5 years. We did not have an adequate system of adult day health care throughout the state. So not only has that not grown, but as centers have closed, no one else has been able to have a license in that place. You all asked the question about whether the AAAs are robust enough to perhaps provide maybe a care coordination system, much on the level that regional centers do. It's really hard to generalize about the AAA system. I would suggest that if you're going to continue a dialogue on this issue, you might want to have some folks talk a little bit more about that. I know our experience is that in some communities, AAAs are, they provide some services. They may have some folks on their staff who has some training and expertise, but in many cases, they're primarily contract managers for services. So it certainly could be envisioned to rise to that level, but it would certainly take a lot of work. One issue that we didn't talk about much here today, there was a fair amount of conversation about how do we get people who are in nursing homes out. We are at least as much, if not more, concerned about the diversion of people from nursing homes in the first place. Most folks who go into nursing homes, particularly if they're seniors, come from a hospital stay. Hospitals, we know, through financial pressures from the insurance companies, have shortened hospital stays. People are released in a far higher acuity level and still having very high needs. So very often the plan is just transition them to the nursing home, where there's often promise of rehab services, and then they'll be on their way and out the door. And again, if more care was taken at the time of hospital discharge, and there were, in fact, the array of services needed to support that person in the post-acute care stage, they wouldn't need to go into that hospital in the first place. The last point I want to make is about the fiscal. I know that Commissioner Mitchell raised that right out the door when when Ms. Sugarman spoke about the six components of long-term care. So I think, like anything else, we look at things that need investment, and in most cases, if the investments are in the right places, you save the money in the long term. I believe Ms. Juring used the figures that 52% of our funding is going into institutional care versus 48% other way around in home and community based. I guess the point I would make, those numbers maybe sound like, well, that's a pretty balanced system, but I want you to look at, that's just the percent of dollars. Let's look at where the people are. So we're looking at about 430,000 folks in the home and community based versus maybe 60,000 in the nursing home. So again, while the money may look like it's being fairly split, that's about 7 times more people in the home and community based. So, and this just segues directly to Dr. Hendrickson's really thorough study. There isn't new money. You know, we're realistic about that. The state is looking to cut. We're still in crisis. But there is money in the long-term care system. And this state really does need to find the way to do global budgeting within this whole long-term care financing continuum, which means making some hard political decisions around the commitments that have been made to the institutional nursing home care and the dollars that are locked up there. Other speakers have addressed to that. Dr. Hendrickson has specific recommendations in his report on provisions of that law that could be addressed and free up some of those dollars so that we have the capability to manage the right care in the right place at the right time. Thank you.
Thank you very much. The next request I have is from Laurel Mildred. Ms. Mildred, if you'd come up, please. Welcome. Thank you for coming today.
Thank you. I came without my glasses, so you'll forgive me for... My name is Laurel Mildred, representing Californians for Olmsted. We work for full lives in the community for people with disabilities across the lifespan, from children to older adults. I talked with staff prior to this hearing, and I understood that a large focus of this first hearing was going to be framed around aging issues as well as sort of the integrated system, and that a more comprehensive look at the issues of people with disabilities would be brought in at future hearings. So I'm encouraged, and so I didn't prepare comprehensive remarks speaking to Olmsted. I saved that for later time. I tried to think of how I could assist your deliberations today, and so there were a whole variety of scattershot issues that came up, and I wanted to just mention some resources that I can share with you that you may be able to bring into your deliberations in the next hearings. I wanted to mention that SB 998 that Dr. Hendrickson referenced earlier sets about trying to create a uniform assessment, which starts to get at the issues, Commissioner Mitchell, that you were raising. So we're participating in that bill. I think that I would like to echo AARP's recommendation that we really dig down into that very thick long-term care financing report, because we also think there's a lot of low-hanging fruit. There are things that can be done more efficiently, better, and it's a really thorough, comprehensive policy analysis and deconstruction of some of those things. We think the whole conversation, I appreciate Deborah Doctor, I'll just echo what she said. We think the whole conversation would benefit by being more aligned with an Olmsted framework and really starting from federal law, the Americans with Disabilities Act, and where that takes us. It's very positive for advocacy that where people want to live is in the community, and that where it is cheapest for people to live is in the community. So it's nice for advocates that that is aligned, and I think it's very good to keep those things in mind as you embark upon these discussions. I think that one of the things that might have helped today's discussion was perhaps a kind of picture of the long-term care system. The complexity is very difficult to get a hold of in one meeting. The Senate Subcommittee on Aging and Long-Term Care created a map of all of the different long-term care services. I'm going to send that to your staff. Perhaps that will contribute. I observed that there is some confusion around issues that are federal issues versus issues that we have control over in the state. We find it's very helpful to work on both of those issues, but to really call out what is a federal issue, what's a state issue. And for federal issues, we develop an agenda that we may want to lobby on, and for state issues, we understand we may have more direct control over. So I would suggest that might be a framework that would be helpful to you. I wanted to go back to early in the day, federal health care reform and some of the impacts. I'm not an expert, don't want to be bill myself that way, but I do want to say that there was a very big impact that wasn't mentioned today affecting people with disabilities, and that is that the lifting of the prohibition against discrimination based on pre-existing conditions is huge for children and adults with disabilities in terms of their ability to work and get health insurance. For years and years, people with disabilities have been told that they would not be able to work because they would not be able to get health insurance. They're not able to compete in the competitive job market, and there are disincentives to them losing their health care if they go into the job market. So we can start upstream by noticing that when we deny people education and opportunities based on their disabilities, we are contributing to the challenges in the long-term care system. I appreciated Director Dauscher, whose responsibility is aging, sort of took a stab at giving an overview of the disability populations and programs. I think it would be helpful to bring in some of those that are responsible for those. I did want to mention that mental health wasn't referenced, and that's very important, so I appreciated, Commissioner Anderson, your pointing that out. I wanted to also say I think that there are differing points of view on the woodwork effect, and that Dr. Steve Kay from UCSF has written a very important journal article for Health Affairs. And I think that you might want to talk to him in a future hearing. And meanwhile, I will share with your staff his journal article on the woodwork effect. I'm not an expert in that, but there are those who are. I wanted to disagree with the characterization that California has a no wrong door policy. I think that a no wrong door policy implies a single point of entry, and that our system, our long-term care system, is characterized by fragmentation. Almost every door is the wrong door in California. And I think that the aging and disability resource centers that were discussed here are an attempt to create an overlay to a complex system that creates the function of a no wrong door system. So basically you're going there and they have all the resources to connect you to the various fragmented systems. But we don't have a no wrong door policy in California today. IHSS fraud and abuse. There is a very good investigative report that I will share with your staff that dug in and indicates that it's less than 5%. And since the original press that went out said that it was 25%, I think it's really worth digging into those issues. I will share that so that you can look at that more closely. There was testimony that there are people who may not even qualify for skilled nursing facility care. This is described as a problem. So it was described that there are people who might not be going into a nursing home that are getting IHSS. And I want to just mention that Dr. Hendrickson said at a recent Senate hearing that community services and certain programs like IHSS are so cost effective that you could serve many people who wouldn't be in a nursing home and still be cost effective under, for example, waivers. So I think we want to be cautious about identifying it as a problem that people are getting those services, because those are people at risk of going into nursing homes, and this is very cost-effective prevention. So I think we want to kind of not assume on its face that that is a problem. We want to look into it. I also want to say that the independent living centers are part of the Community Choices program that was referenced, and I would really encourage you to invite Ed Ahern from the Westside Center for Independent Living, who is a lead organization, to describe for you what those transition services are so that you can have a better picture of them. And one of the things that they've learned is that there are people in skilled nursing facilities who don't meet medical necessity. They're going in, they're helping transition people out on a waiver, and so people have to meet the same level of medical necessity for the waiver to go live in the community as they do to live in the SNF, and they're finding people living in the SNFs that don't meet medical necessity. So you've got some really big issues when you dig into them. So I encourage you to talk to the people that are doing the transition programs. And I think my final point was that I wanted to just say that this is a lot of conversation about health and human services, very appropriately. But if you also really consider Olmsted, you're going to want to really get outside of only the health and human services arena and move into housing and transportation and education. Because what we're trying to talk about is people living independently, self-sufficiently in the community. You can't do that if you can't get out around the community to go to the doctor, to participate in social life, if you don't have a place to live, or if you can't access disability services in your community college and you're an adult with a disability. That was all I wanted to say. Thank you.
Thank you very much. Lots of information packed into a short period of time there. My next request is from Michelle Rousey. Can she get up here and talk? There I am. We'll get you the mic here.
fine. I'll move the microphone over.
Thank you.
You're welcome.
No, he's good. I'm good right here. No, he's okay. Thank you.
Thank you
I
for welcome, and thank you for coming.
Yeah. My name is Michelle Rousey. I'm the chair of the Public Authority Advisory Board for IHSS in Alameda County. I actually had come for a hearing on Medi-Cal today and the cuts and things that were happening with cuts for that today. But when I heard about your continued hearing today, I felt it necessary to remind you of the need of community-based services. And many people here today have talked to you about all the different services and how things are needed, and they've spoken probably much better than I could ever talk to you. But for me, I've been my functional index is below a 4, and many people like myself who can't do a lot for ourselves are not assessed in a way that is universal from one institution to another. And for our IHSS, there needs to be across the board unification, and so that we all are assessed in a similar way. The index was never intended to be used to cut services off, as you probably already know. But please make sure that funding for community-based services is there for people, because I would not last long in a nursing home. And like many have said, that people would rather die than go into a nursing home. Well, I know I've almost died being in hospitals, but going to a nursing home with a lack of care that I now get at home, which is very cost-effective and has kept me out of the hospital for several years, I would not get that same level of care even in a nursing home. So, and it's kept me alive. And I do not want to be forced back into institutional care, and I know many others that would not want to either. And coming out of a nursing home, and having those resources set up for you is phenomenal. You've got to have those resources set up for people, because, it's not just about housing, it's about having IHSS and other people set up to be able to show you the ropes and be able to follow you and let you know and get you set up with a worker and other resources. So please do what you can to make sure these resources stay in the community. Thank you.
Thank you, Michelle. Appreciate your testimony. I have one other request from Robert Harris. Mr. Harris? Welcome. Thank you for attending our hearing today.
Robert Harris, on behalf of Service Employees International Union, our members work in both IHSS and in nursing homes. First, I want to agree with Dr. Hendrickson, who said that California came late to the idea of what he called provider taxes, and what in the nursing homes and other things are called quality assurance fees that California is finally doing. There's a lot of data that shows that a sustained, stable workforce is key to providing quality care both in nursing homes and in IHSS. That's why when AB 1629 was passed, that established a provider quality assurance fee for nursing homes, we made sure that there was a section of it that made sure that facilities that provide stable workforces and paid those workforces decent wages, which provided the stability, got reimbursed more. I know that 1629 is not a perfect bill, that our friends at AARP and the Alzheimer's Association, Disability Rights California, all of us are committed to making it a better bill, and so is the nursing home industry, that we're all talking about how to make it work better. But you got to understand, I think, that if you want nursing homes to be quality facilities and you don't want them to go bankrupt, and you want people who are getting care in a place that no one wants to be getting care, get the best possible care they can get. So that was the reason for that formula. I don't think it's just free money to take and move around, because it is a result of the quality assurance fee that the nursing home industry is actually paying. But that doesn't mean it can't be improved, and we're committed to working to improve it. As regards IHSS fraud, we made sure that in AB 4X19 that there was language that would actually look and see what was really there and develop a report, and not only see what the actual amount of fraud was instead of all these anecdotal tales, but also figure out ways to prevent it from happening. And so that's part of the law. We didn't agree with much of that law, but that part of it we made sure was in there so we would deal with facts and reality and not hypotheticals. Also, as Director Anderson said earlier, part of what drives people to think there's fraud in the program is the fact that family members get paid to provide services. The other side of that is that the family members getting paid to provide services was a California-only funded program until 2004. In 2004, we had a budget problem. We realized we couldn't afford to pay for that anymore, and we went to the feds and we said, under a waiver, would you do this for the first time in the country? Would you share in the cost of having family members be paid for taking care of their people? The feds approved that waiver really rapidly, and they did it because the Department of Social Services and Department of Healthcare Services showed them that there was cost neutrality for the feds. In other words, the feds were at least coming out as well financially by paying for this as by not paying for it. So the feds have an understanding of a value of family members providing services. We think there's even more than that. Earlier, one of the witnesses talked about the 1115 waiver, the hospital waiver, that we think should be much more. And the language that set up how California's going to deal with it emphasized home and community-based services. We think that not only do the feds get cost neutrality on a Medicaid end from IHSS, but they enjoy huge cost savings on Medicare, which is federal-only payment program that when we prevent people from getting sicker by providing them with IHSS, when we prevent them from going into hospitals, and if they're in a hospital 3 days and they're a Medi-Medi, which 1.2 million Californians are, if we prevent that, then this federal government saves the hospitalization cost and the first 30 days of the nursing home cost. That's totally a federal spend. Now, we've been saving them tons of money by stopping people from getting sicker and ending up in emergency rooms and hospitals and nursing homes that are federal payment for years. We think that there is a way that we can get the federal government to agree to share part of that savings back with the state of California, which would make it really fair. We've led the nation developing home and community-based service programs that are broad spread and keep federal costs and Medicare costs down, if you want to call it cost slope like that down, but just generally we've saved them a lot of money. And we think it's only fair that they share back that, and we're advocating that case in the 1115 waiver work groups. We think there's a good chance it should succeed. The feds CMS has actually done these kinds of sharebacks with private companies, never before with the state. We think that it's time for a state to go to them and say, look, if you do it with the private company, it gives you cost savings for like disease management in Florida, that you should do it with California, who's been saving you a whole lot more money than that ever possibly could. So we look forward to working with you, with your staff, as you move forward on this issue. This is the tsunami of California. There's lessons to be learned in other states, but other states have lessons to learn from what we've done here in California. There's also the other dynamic that Director Anderson brought up. This IHSS was a social model program, but the money that it saves and the money that we can get to fund it ends up being the medical model system. And if someone could figure out another way to do it, we would be open to it. But we think even if it's a social model program and it's saving federal medical savings, then those savings should help pay for the program. We look forward to working with you and your staff as you move forward and develop a plan. We think it's absolutely imperative that it happen as soon as possible, because like I'm on the cutting edge, the leading edge of the tide that's going to wash over us. So I'm committed personally to working with you to fix this.
Thank you. Appreciate it. Okay, I had no other requests to speak, and so I will adjourn our public hearing. We're going to reconvene in about 10 minutes down in room 125 for lunch and our business meeting, and then I think Laura Chick is coming to talk to us at 1:30. So we'll check. State Inspector General. And Sue, I want to talk to you after the meeting about the water outline.
Did you see anything you liked?
Yeah, I like almost all of it.
Hey, great. Thank you. Thanks for coming.
Thank you.
Yes, we do.